5 or 10 minutes. And
that is what we are doing every time now.
And that can be added on to the clinical
Yeah.
discussion. Because
Yeah,
most of the doubts that the candidates may be having can be cleared during the clinical discussion itself.
Yes.
This
Good evening,
is,
Rishi Sethi, sir.
the presenting department is from Lucknow, is it?
Lucknow.
Yes,
And
sir.
which is the discussing department?
Jipmer.
Jipmer.
Jipmer. Okay. Jipmer people are also ready, it's not so?
Yes.
Good evening, Taran, sir.
Jagan. Hi, Jagan.
Hi, sir. Hi.
Hi, how are you?
Fine.
You are as cheerful as always.
Yes.
Hi, Anil, how are you?
Hi, Dr. Manjura. I'm fine. I'm great.
Where are you now?
Pardon?
Anil, where are you now?
I'm in one corporate hospital in Delhi called Max Hospital.
Oh, it's very famous. I think.
Well, yeah. Yeah. So I've been there for a long time, almost 10
No,
years.
after Sri Chitra, you straight went to Max Hospital, or you had a?
No, well, I had stints in a couple of them, then went to Bangalore in Manipal Hospital, Bangalore.
Oh.
5-6 years there, and now I've been here for 10 years now.
Oh, okay.
Good evening, sir. But sir.
Hi, good evening, Hari.
Hi, Hari, how are you?
Good evening, sir. Hi, Hari.
Hari,
Yes,
how
sir.
are you?
Good evening. When, sir? Good evening.
Good evening. Good evening.
So good evening to everybody.
Yes. Dr. Rishi has joined. Then
Yeah.
Dr. Ajay Bahal is also in the examiners panel.
Ajay Bell, sir, he is there for all our meets.
Okay.
I think a special thanks to Ajay Bell, sir.
Yeah.
Dr. Divedi has joined. Sajan is not there.
Good evening. Good evening.
Good evening, sir. Good evening.
Good evening. Good evening, guys.
Good evening.
Good evening.
Hello, Dr. Bhatt. How are you?
Hi, Dr. Vijay. Fine. Thank you. Fine.
Manjuran, nice seeing you again.
Hi. How are you? How are you, Divadi? How are you?
The students are waiting for you with bated breath.
Good evening, Dr. Erkan.
Hello,
Hi,
Hari.
good evening. Good evening.
So, how is life there?
Hi,
So we
Vijay.
are-
Sabra. Hi, Vijay. How are you?
Good. Nice seeing everybody.
Rishi, we will start with you.
Okay.
Yeah.
Usual. Dr. Dwivedi, how are things in Lucknow?
Lucknow is cool. I think you are asking from the angle of pandemic.
Yeah.
There's only one question nowadays.
UP is doing very well, actually.
No. See, all the pandemic is now concentrated in Kerala.
Kerala.
Kerala and Maharashtra.
We have already started the third wave.
Yes.
We do not have a
We are continuously going into third wave.
Kenu, as
It is
usual,
going like not an epidemic, but now it has become endemic something. Something like that.
Kenu,
Yes,
as
yes.
usual, you guys from Kerala want to monopolize on everything, including
Yes.
60% of the new cases reported are from Kerala. But one thing is there. See, a study has shown that Kerala actually reporting of cases is it has to be multiplied by 6 fold, while in Bihar it has to be multiplied by 100, and
150. UP 150.
UP 100 or 125. So obviously, underreporting may be one of the reasons also. Kerala underreporting.
Underreporting may be in the government data, but I am also talking from the private data. And private data also is showing less than 0.01% positivity. Private data.
No,
that's true.
it is not that somebody is underreporting it. Probably many patients who are in villages and all, they may be contacting the disease and they may not be detected. That may be the problem.
So it is only comparable to what we had at peak.
Absolutely.
I can only compare it what we had at peak. At peak, our positivity rate had gone up to at one point of time it was 70% sample positivity, 70%. And from there it has come to 0.01, less than that. So even I'm only talking about the private data.
Yeah, but also the hospital beds are vacant. You know, there are no COVID patients in the
There
hospital.
no, hardly 1 or 2 patients. I think there is no patient in our wards.
Yeah, I think
Who is
see,
giving the countdown?
those are things which
Most of
cannot
the
be hidden.
states, most of the states have got herd immunity now, 60 to 70%.
Of course, yes.
Only
Of
Kerala
course.
and Maharashtra are
Are
lagging
the ones-
behind. And hence we have the load of cases.
Actually, the test
Rajesh,
results show that Kerala has got
Rajesh,
positivity
is
of
it time to start?
50%.
Now, is it that this is some other, is it same the Delta or Delta Plus as in Maharashtra? That is,
No, it's Delta. Not Delta only.
it is
Yeah.
still.
Kerala, it's Delta. Around 80% are Delta.
Hari, is it time?
Yeah.
Yeah.
It is time, sir.
Very
It's
good.
time.
Rajesh,
Give a
is it
countdown.
time? Who is giving the countdown? Rajesh,
He's muted.
who is the person who is in the audio vision?
No.
Hello, good evening, sir.
Yeah.
Who is
Give a
giving the
countdown,
countdown?
Ritesh.
Ritesh.
Swati is who is presenting? Swati is presenting.
No, sir, Dr.
No, I think that Ritesh is one of the residents from Jipmar. We've got, please, from the admin side, who is the person today? Is it Rahul?
So from the admin side, I'm there. My name is also Ritesh.
Okay.
Oh, I see. No wonder.
Yes, sir.
Who are the
Rajesh, you give a countdown.
So I
Chopra,
think
you start and I will say a word and then we'll give it to Veda sir. And then
Welcome, Rishi. Welcome.
Rishi, good evening.
Okay, Rishi.
Hello,
so
Rishi.
I think
Good
so.
evening, sir. Good evening. Good evening.
Yes, give
Hello.
the countdown.
Countdown.
Sir, I think we are already live.
Yeah.
Already live. Okay.
Yeah.
Dr. Chopra, you can start.
Good evening, ladies and gentlemen, and a very warm welcome to another edition of Heart Failure Clinics. This is the 6th edition, and we have had 5 wonderful cases and with fantastic discussion led by our stalwarts. These meetings give our students a chance to interact with the potential examiners, also to find out the way that they think, and also to learn from them. You know, it is not just that you people are learning, we people have had a great deal of learning from these cases. So without further ado, let me request President Dr. Harikrishnan to say a few words, and then we'll start the discussion.
Yeah, we had a small gap in between due to the COVID pandemic. We did not have the clinics for the last 3 months. I think again we are restarting. So this time we have presentations from KGMU, and the students are from Jipmar, and we have a panel of experts. As you all know, they are the best examiners you can get. So, over to Dr. Venugopal, who is the coordinator of this program.
Thank you, Hari. Good evening to you all. We now go to the sixth edition of this brilliant academic program. I have been enjoying it, as Dr. Chopra said, and we have been enjoying this as much as the students. Today we have a presentation. First, the presentation basically is from KGMU Lucknow. We have first a talk by Dr. Rishi Sethi on the newer drugs in heart failure, Versigouat and Mavacamten. And then we have a case presentation by Dr. Ashish Tiwari. The discussions of this case will be from Jipmar, Dr. Kamlesh Kumar, Dr. Valsal Singh, and Dr. Ritesh Kumar. And then after that, there will be a take-home message by Dr. Pravesh from KGMU, the Host Institute. So I think without much ado, let's go to the first talk by Dr. Rishi Sethi on the newer drugs in heart failure management, specifically Versigouat and Mavacamten. Dr. Rishi Sethi, please. Are you?
Yes, sir. Yes, I am just.
Okay,
Can you see the slides, please? Yeah.
Oh, sure, sir.
Well, I would like to just present a small clarification. The topic that was allotted to me was the paradigm shift in the pharmacological management of heart failure. So I'll be basically speaking about how heart failure, pharmacological management of heart failure as it stands today in 2021. Maybe a little bit about omecamtiv and Vericiguat, and basically about the overall management, pharmacological management of heart failure with ejection fraction, or reduced ejection fraction. So
I apologize for the
no. So maybe there was some. Yeah, sorry, sir. So good evening, everyone. Eminent senior members on faculty, organizing committee on this panel, colleagues, ladies and gentlemen. First of all, let me just extend a very, very special thanks to the organizing committee to have given KG, the King George's Medical University, my parent department, the chance to be the host for this session. And the interesting point of this session of around 2 hours would be the case presentation by students of King George's Medical University and interactions with various other students of JIPMER and other medical colleges. So that's going to be supervised by a very, very illustrious panel of experts, and that would be the mainstay of today's talk. My job is to warm up the session, today's session, and in that effort to warm up the session, my talk would be on the paradigm shift in the pharmacological management of heart failure with the reduced ejection fraction. Well, over the last 50 years, the target of therapeutic targets for management of heart failure have shifted from a hemodynamic model to a neuroendocrine model. Before 1990, the approaches to heart failure were essentially considered on a hemodynamic platform, and therefore diuretics, digoxin, vasodilators, and inotropes were the mainstay of the treatment. The decade of 1990s brought an interest in the blockage of renin-angiotensin system, sympathetic system, aldosterone system. So numerous clinical trials very, very conclusively proved the role of beta blockers, ACE inhibitors, ARBs, and aldosterone inhibitors in the management of heart failure. And by the end of that decade and the early 2000s, their role was firmly established. And these three drugs, the ACE inhibitors, ARBs, beta blockers, aldosterone, along with diuretic for symptomatic improvement, became the mainstay of treatment of heart failure in that time. The first decade of 2000 brought a renewed interest in the biomechanical aspects and the arrhythmic aspects related to the poor prognosis of heart failure. And therefore, a lot of clinical trials of CRTs and ICD came, and their role in heart failure was established. Now, as we enter into this third decade of this century, the goal, as we look into the future, the goal is towards a more personalized care for the heart failure patient, a more precision medicine kind of a thing that involves genomics, proteomics, the involvement of biomarker, imaging, biosensors, and how they are going to interplay and make the life of patient better and longer in times to come. Now, somewhere between that established heart failure therapies, the pharmacological therapies of the late 90s and early 2000s, and the futuristic therapies that I'm talking about, two class of drugs came around. That was the ARNI and SGLT2 inhibitors that again in the last decade, came up surprisingly very fast and also established their role in the management of heart failure very, very conclusively, and now are at par with the initial drug management. So why do we need these continuous improvisations in the management of heart failure, both pharmacological and otherwise? It is because despite all treatments, the heart failure mortality remains, the overall outcomes remain pretty bad. And as seen in Trivandrum Heart Failure Registry, of most of you were part of and were being led by people on this panel, we saw that 1 of every 3 patients who was discharged from hospital had to be readmitted again during the course of next 1 year. And 25%, about 1/4 of the patients, need hospital admission twice. And this hospital admission was not only causing more problems to the patient, but at the same point of time, it was one of the very important markers of higher mortality. The mortality was up to 3 times greater in the people who required rehospitalization as compared to those who did not require so. So why was this happening? Maybe it was happening because, as has been proved by one of the papers from Dr. Harikishan, that these patients were on suboptimal guideline-mediated therapy, but they may also be due to inavailability of more advanced and appropriate therapy, because at that point of time, presumably ARNI and SGLT2 inhibitors were not present. And so there was a need for future compounds, and probably these new agents and these new class of agents filled in the gap. And we hope that in times to come, this kind of rehospitalization, mortality, and overall prognosis of heart failure patients may improve with their use. So let's take a look back to the last decade and how it changed the pharmacological management of heart failure. The ivabradine was first kid on the block. In 2015, it got approval to reduce the risk of hospitalization for worsening heart failure in patients with stable symptomatic chronic heart failure with ejection fraction 35% or lower, and in whom the resting heart rate was more than 70 despite maximum tolerated dose of beta blockers or contraindication to beta blockers. And essentially, this guideline, this recommendation was pushed by a large trial, that is SHIFT. When ARNI came into picture, it actually preserved the beneficial effect of the angiotensin blockage, the renin-angiotensin system, by the blockage of AT1 receptors. But at the same time, it also combined the enhanced effect of the natriuretic peptide system by its inhibition of neprilysin, and that enhancement of this natriuretic peptide system led to decrease of blood pressure, decrease of sympathetic tone, decrease aldosterone level, decrease fibrosis, and increase in natriuresis and diuresis. And this overall combination of sacubitril and valsartan seemed to have hit the sweet spot in the overall therapeutic target for heart failure. And it was pharmacologically and pathophysiologically very sound. And this soundness, pathophysiological and pharmacological soundness, was repeated time and again in various clinical trials that were performed between 2012 and 2021, the largest of them being Paradigm Heart Failure, in which you had striking clinical benefits in almost all the features established. And this large trial established the role of ARNI in stable heart failure patients. And then there were future trials that deserve mention that actually enhanced the role of ARNI in hospitalized patients. The first one of them was Transition study that actually saw the role of pre-discharge initiation versus post-discharge initiation of ARNI. And essentially both these strategies were similar, going on to interpolate that you can start ARNI during hospital setting pre-discharge, and it is equal to starting it in a more stable phase. And built upon this trial was a Pioneer Heart Failure trial that actually compared the pre-discharge initiation of ARNI versus pre-discharge initiation of enalapril. And here again, although the endpoints of Pioneer Heart Failure are a little soft endpoints in terms of decrease in biomarkers, but yet pre-discharge initiation of ARNI proved to be superior to pre-discharge initiation as compared to enalapril. And therefore, it was extrapolated that ARNI can be safely started with beneficial clinical effect, even in the in-hospital setting pre-discharge. Another trial that deserves mention, although there are a lot of trials, is PROVE Heart Failure, which actually studied the role of ARNI in reversing the remodeling that is associated with heart failure. And that was, again, a little bit positive trial. And overall speaking, all these trials kind of established the role of ARNI and established the pharmacological promise that it has shown, established in the clinical setting, and now it has become a part of our armamentarium. The last drug to come into this armamentarium, and very, very strongly, we all know about it, is the SGLT2 inhibitors, essentially a glycosodic drug developed for diabetes. But then it by this virtue of diuresis, natriuresis, decreased preload, decreased wall straight, decreased afterload, and it has some myocardial energetic mechanisms, and various combinations, various hypotheses were given. But despite this various pathophysiological hypotheses that were given for SGLT2 inhibitors, nobody could have really perceived 15 years ago that a drug for diabetes will have such a profound effect in the management of heart failures. And these hypotheses have been somewhat proved in clinical trial. And I must say that clinical trials data with SGLT2 inhibitors is actually now really outgrowing the trial data that we have for ARNI. And you have a lot of clinical trials that have seen the role of SGLT2 inhibitors, starting from the primary prevention of cardiovascular outcomes in diabetic patients, going on to non-diabetic patients, and secondary prevention. A host of clinical trials have given very, very enormous amount of robust data to support the use of SGLT2 inhibitors in heart failure patients. The largest of those trials is DAPA-HF and dapagliflozin, in which around 5,000 patients, dapagliflozin was compared to placebo. Almost all endpoints that were studied, including the cardiovascular death and death from any cause, showed marked benefit with SGLT2 inhibitors. And what is really interesting is that this outcome, this improvement in outcome came on a very, very robust guideline-mediated therapy that these patients were receiving. Out of around 5,000 patients, 84% were on diuretics, more than 95% were either on ACE inhibitors, ARB, or ARNI. 96% patients were on beta blockers, 71% patients were on aldosterone inhibitors. So despite these patients of stable heart failure being on this very strong guideline-mediated therapy, dapagliflozin went on to prove too conclusively that it enhances, it improves clinical outcomes, and therefore its role was very, very well established. Add on to this trial was the EMPEROR trial, which studied the empagliflozin, almost similar in pattern to the DAPA-HF trial. Half the patients were diabetic, half the patients were not diabetic. The difference was that in this particular trial, the patients that were enrolled were sicker, they were moderate to severe degree of heart failure, and so the role of both empagliflozin and dapagliflozin was established. And in this particular trial, despite apart from cardiovascular outcome, a composite improvement in the renal outcome was also seen. So as we stand today in 2021, we see that in early 2000s, we had renin 3 targets for attack. That was the renin-angiotensin system, the sympathetic nervous system, the sympathetic system, and the aldosterone system. But now we have 2 more targets that is added in the first line, 2 more pillars being added to the management of heart failure, and that is the neprilysin inhibition and the SGLT2 inhibition. There are other things that are on the periphery, but they cannot be undermined. But they are on periphery because they are either, the data so much is not available. They are in the periphery. They are generating more data, like omecamtiv and Vesugard. And there are drugs that are a little bit on the periphery because their use is restricted to specific subgroups and not every patient. And that is ivabradine, IV iron, and fixed dose combination of hydralazine and isosorbate dinitrate. So when you have so many drugs, at least 5 targets, at least 4 drugs that are addressing these 5 targets, and so many years of experience, the data sometimes can be confusing. So you have to go back to the guidelines to cut the clutter and tell us what to do. And as we see in the guidelines, I would just like to give our younger audience a sense of perspective to how fast the things are changing. This is not far back. This is like 4 to 5 years back, the ESC 2016 guidelines, which showed that we should start patients on ACE inhibitors and beta blockers. If they still remain symptomatic, we should go ahead to add an aldosterone inhibitor. If they still remain symptomatic, then we can use ARNI to replace ACE inhibitors, or we can use CRTs or ivabradine if they fit that specific criteria. So it was a step-graded manner of start of initiation therapy. But if you look today, that is the 2021 modification of the ACC 2017 expert consensus decision. You see, we have to start ARNI, ACE inhibitors or ARBs in all patients, beta blockers in all patients, diuretic as needed. And for all patients, if you look at the second panel, for all patients who fit in the eGFR criteria, meaning essentially every patient who has eGFR of more than 20 and 30, you have to start SGLT2 inhibitor. And all those patients who have got creatinine levels of less than 2.5 or potassium levels within normal range, you also have to start the aldosterone antagonist. So you have to start 5 drugs in one go, and depending upon special situations, you may proceed to an addition of ivabradine or hydralazine diisosorbate nitrate. Similar things are being said in the ESC guidelines, although the main guidelines would be released in the September of 2021, but this was the presentation that was given in the Heart Failure Congress. They have purposely left some columns blank here, and they would be populated at the time when the main guidelines would come. But essentially, ESC also speaks that ARNI, ACE inhibitors, beta blockers, MRAs, dapagliflozin or empagliflozin, on and loop diuretics are all class 1 indications, and they should be started in essentially every patient that is of chronic stable heart failure. How do you initiate and titrate ARNI? Now, if the patient is on ACE inhibitors, you have to give a washout period of 36 hours. You can't be using them simultaneously. And if the patient is already taking higher doses of enalapril, that is more than 10 milligrams, or higher doses of valsartan, that is 160 milligram, you have to start ARNI in 100 milligram twice daily doses. If the patient is taking any lower doses of these drugs, or if you are starting ARNI in a de novo patient, or if you are starting ARNI in an elderly patient or any patient in whom eGFR is less than 30, then you have to start with a lower dose of 50 milligram twice daily. You have to assess it after 2 weeks and escalate to the dose in a stepwise manner so as to achieve a target dose of 200 milligram twice daily. Similarly, with SGLT2 inhibitors, background therapies of ARNI, beta blockers, diuretic agents, if the eGFR is more than 20, you can safely start empagliflozin. If the eGFR is more than 30, then you can start dapagliflozin. And here the dose titration is not required. So coming to the final points of my talk is that while these guidelines kind of put all heart failure patients in one category, every heart failure patient would be different. He or she would be having different clinical pathological features. And based upon that, can you tailor the therapy to a specific part in terms of trying to bring in all these drugs, but at what sequence, in what sequence, if you have to make a choice between which drug to start first and which drug to follow up. And this is a beautiful paper that has come out in 2021. It has divided patient based upon the presence of absence of AF and CKD and heart rate and what is the BP like. And there you can actually divide the patients into these 11 subgroups. And it's a little populated in a complex slide, but you can go back and read them. But if the patient, depending upon what are these various permutations and combinations of these various clinical factors, you can actually go on to decide which drug to initiate first and which drugs to follow up and which drugs to avoid in various clinical setting. And here essentially we see that SGLT2 inhibitors, actually, become the first drug in almost every clinical setting, barring a very few clinical setting. Now we have another new kids that are, coming on the anvil. They are generating more and more data. Omecamtiv, galactic heart failure trial. Vericiguat is also coming on the block, but we have to give them a little more time to come up to the same level as the established roles. So if we use our present knowledge and present experience and follow the guidelines and try to put our own clinical judgment into picture, and we make these good choices for our patient, then probably we may ensure a good future for the specific patient and overall patient population of heart failure with a reduced ejection fraction. I thank you for your time, and I look forward to the clinical discussion with great expectations. Thank you.
Thank you, Dr. Rishi. It's a brilliant talk on the paradigm shift in heart failure. As you said, nobody ever expected that a diabetic drug would become a keystone in the management of heart failure as SGLT2 inhibitors. I think we'll have the discussion of this topic at the end because there's some time lag. We'll go to the next part of the presentation, that is the case discussion. We have 4 examiners, probably the cream of cardiology in India. Dr. Dwivedi from the Host Institute of KGMU Lucknow, Dr. Anil Bhatt, consultant cardiologist, Max Hospital, Delhi, was former professor of cardiology at Sri Chitra Tirunal Institute of Medical Sciences. Dr. Jagan Mohan Taragan and Dr. Rajan Joseph Manjaran has been our examiners right from the beginning, and I think you must all be very familiar with them. So without wasting much time, let us go to the clinical case. This case, a short history of this has been already given to the examiners. Can we ask the examiners to proceed with the case? Dr. Taragan and Dr. Manjaran. The case is being presented by Dr. Ashish Tiwari from KGMU Lucknow. Dr. Ashish, are you ready?
Sir, if I may add, Dr. Ashish Tiwari and Dr. Swati Sharma, 2 people will be presenting.
Okay. And the discussing PGs will be Dr. Kamlesh Kumar, Dr. Vatsal Singh, and Ritesh Kumar from JIPMER, Pondicherry. I think they are also ready.
Is Ashish and Swati presenting the case, or?
No, sir, the case is being presented by Dr. Ashish Tiwari.
Okay, let them present the case for 5 minutes for presentation.
Okay.
Yes. Good evening, sir. My today's clinical case is a 61-year-old male who is diabetic type 2 since 10 years, resident of Lucknow, presented with chief complaint of breathlessness on exertion for 1 year and cough for 2 months. History seems to be reliable, given by patient himself. Relevant past history that he had history of anterior wall MI 18 months back, managed medically. History of present illness. Patient was having dyspnea on exertion for last 1 year, which was serious in onset, gradually progressive in nature. For initial 6 months, he had dyspnea on exertion with slight limitation of physical activity, NYHA class 2. But in last 6 months, he started having dyspnea on less intensity household work also, becoming NYHA class 3. Patient also complained of orthopnea 3 months back, which improved after taking oral medication at some local facility. Though he complained of increase in urine frequency after taking that drug. No history of PND and orthopnea since last 2 months. Cough. Patient was having cough for last 2 months, which was especially at night and on lying down position and relieved in sitting position. Cough is not associated with sputum production or hemolysis. There was no history of fever, COVID-19 infection in past or any recent infections. No history of lower limb, abdominal or facial swelling. No history of angina. No history of syncope. No history of burning sensation, numbness, weakness or ulcer in any of the limbs. No history of blurring or loss of vision. No history suggestive of tuberculosis, bronchial asthma or COAD in past. Relevant past history that patient had anterior wall MI 18 months back for which he was admitted in our hospital. Presentation at the next hospital that patient was Philip class 1 on day 2, non-thrombolized, and chest pain has subsided at around 12 hours of window period. Referred from peripheral center, and the time of presentation to cardiology department Lucknow was at 30 hours. Family opted for medical management, and ECG at that time suggestive of sinus rhythm with QS in V1 to V4. Echo was suggestive of LAD, hypokinesia in LAD territory with EF of around 36%. Patient was discharged on guideline-directed medical therapy with plan to further optimize the therapy on follow-up visits. But patient lost to follow-up since then, but was compliant on the given drugs. Drug history. Patient was discharged on dual antiplatelet therapy with aspirin 75 mg and clopidogrel 75 mg with atorvastatin of 80 mg with metoprolol of 50 mg OD and ramipril 2.5 mg OD, torsemide at 10 mg OD with aldactone 50 mg OD and anti-diabetic drugs, oral hypoglycemic, metformin 500 mg BD and glimepiride 2 mg OD. And his current medications are as follows: continuing taking dual antiplatelet therapy and statin with metoprolol 50 and ramipril 2.5 mg OD. Torsemide was increased from local facility when he complained orthopnea to 30 mg OD, 20 in the morning, 10 in the evening, with aldactone 50, pantoprazole 40 and metformin and glimepiride as before. Some 61-year-old male, diabetic type 2 since 10 years, controlled on oral hypoglycemic agents with history of anterior wall MI 18 months back, non-thrombolized on medical management, presented with insidious onset and gradually progressive dyspnea from NYHA class 2 to class 3 for last 1 year, with orthopnea 3 months back relieved with oral medications, along with non-productive nocturnal cough for last 2 months.
Okay, is that the story? Oh, right. Okay, Swati, have you finished your story?
Yes, sir. History has been finished.
Okay. Do you think that you have missed any important, relevant part of the story? Because after all, this is a patient with an anterior myocardial infarction who has developed a complication. Let me ask the JIPMER people. Where is the JIPMER people? Are they ready? JIPMER students?
Yes, yes.
Okay. So we have, did you hear the story?
Yes, sir.
Yeah. So from the story, do you like to ask a few more questions to make some more clarification?
Can you put your video on, Dr. Ridesh?
Any other story which you should, which part of the story should have been asked for?
Others,
Well, I think a history of palpitation should be definitely asked for, because here is a patient who has deteriorated, and one of the problems that can cause deterioration is development of a complication. And one of the major complications which can actually cause deterioration of the cardiac status is development of atrial fibrillation. So I think that part, that story you should have asked, and if it was there, whether the patient had an irregular palpitation, that should have been asked for. Second, of course, you have mentioned angina. That's quite fine. The deterioration of the same problem. In addition to cardiovascular system involvement, some of the patients can deteriorate because of extra cardiac problems. One or two, can you mention? Can also form part of the story. So somebody wants to take a brilliant story.
Any decrease in the urine output or any hospitalization in between?
Decrease in urine output, reducing the medicines, and also sometimes development of systemic disease like thyrotoxicosis, patient developing anemia. All those can actually cause a deterioration of the cardiac status. So one or two questions, whether he lost weight, whether he is having any bleeding episodes, all those things will give the examiner an idea that here is a candidate who has gone into every aspect. I think that those things, probably in this patient, it may not be relevant, but that will give an idea to the examiner that here is a brilliant student. So,
yeah, and this patient also, like, as he told, like having a complaint of increased breathlessness for this NIA 2, NIA 3, and NIA 2 to NIA 3 had like some 6 months back, right? If I heard right. Though, like this, because like history is going towards anterior MI. So if any LV dysfunction or any annular dilatation, so any MR, if developed, so like if any volume overload condition, yeah, just you rightly said, palpitation is there or not. And that is too when, whether it is regular or like whether it is present even at the rest or whether any association with exercise.
What is the most important reason for a patient with anterior myocardial infarction progressively deteriorating and presenting with breathlessness?
Yeah.
So LV dysfunction.
LV dysfunction.
What is the mechanism of LV dysfunction?
LV dysfunction. One may be the remodeling.
Ventricular remodeling. And what are the changes occur in the ventricle when there is a ventricular remodeling? Can you describe the changes?
Yes, sir. So in ventricular remodeling, the myocardial part, it get thinned out and stretched, sir.
That's
and
one
then, normal part, it get hypercontractile, sir. And so initial part, it may be benefit to the patient because ejection fraction is decreased because of this, and filling pressures are decreased. But as the progress, after 4 to 5 years, this
why did you see the benefit of ventricular remodeling is due to what are the mechanisms?
Decrease in the LV filling pressure, sir.
Okay, very good. Second,
and second is ejection fraction is maintained because LV this part is dimension size is increased, sir. So initial part ejection fraction is also maintained, sir. Normal.
No, wrong. Ejection fraction is not maintained. What is maintained? What is maintained?
What is maintained at a higher end diastolic volume? That is the most important thing you should tell.
Yeah. And what is maintained?
Yes, increased cardiac output, cardiac output at the cost of increased filling pressure.
Yes,
stroke volume is
stroke volume is increased and cardiac output is maintained. That's the most important. I also agree that there can be reduction on the LV and diastolic pressure. So in a way, initially ventricular remodeling is beneficial. So
increase in the stroke volume is at the cost of what? That is the problem with positive remodeling. What is the cost to the patient?
What is the cost? At what expense?
What is the cost?
At the cost of increased filling pressure, sir.
No. Not necessarily. Yes, it is increasing in the wall stress.
Mostly, sir, this filling pressure,
please listen to me. Please listen to me.
1 to 2 millimeter of mercury for the increase. But if it is more than 1 or more than 2, like it is.
Please listen to me.
Listen.
Right? It increases the wall stress. Right? The ventricular wall stress is the most important thing. It increases means what happens? Oxygen demand increases. So there is a cost at which the stroke volume is maintained. And that is why these patients will overall, simply because of positive remodeling, start getting heart failure or the ventricular failure. What are the secondary effects of remodeling? Can you tell us? What happens to the overall shape of the left ventricle? It becomes more
globular.
Yes, more spherical or more globular. It obviously is less efficient as a pump than an oval. Right?
For the students to understand, sometimes I usually say that the heart, which is like a rugby ball, becomes a football.
Yeah, that's right.
So
Correct. That's right. From a rugby ball, it becomes a football. And then
football.
what happens? With this sphericity index increasing, what happens? What happens to the papillary muscles, the alignment?
So
What happens to
because of
mitral valve closure?
dilatation, because of the LV dilatation, sir, papillary muscle, the MR can develop regurgitant.
Tell us in steps that you understand. It causes tenting of the mitral valve, right? There is something called the tenting index, isn't it? It's typical of dilated left ventricle, and that causes mitral regurgitation and annular dilatation. I mean, annular dilatation is part of LV dilatation, and that causes mitral regurgitation.
Yes.
These are the steps by which, without arrhythmias, without a second episode of ischemic insult, patients still can progressively go to heart failure with the first episode of MI itself. That is called progressive positive remodeling. And most of the drugs are addressed to reverse this progressive remodeling. Can you tell us the drugs which are addressed to the progressive remodeling, positive remodeling?
ACE inhibitors are the most common used drugs.
Yes. Already you've got a very excellent talk. You should just enumerate exactly what you have imbibed from that talk. Yes, ACE inhibitors.
Can you tell me what are the drugs which can actually reverse the ventricular remodeling? So you mentioned ACE inhibitors can actually prevent ventricular remodeling, but can you tell me few drugs which can actually reverse ventricular remodeling?
What's ACE inhibitors, beta blockers, ARNIs and SGLT2.
Which beta blocker has been shown to reverse ventricular remodeling?
Carvedilol and metoprolol.
No, not metoprolol. Carvedilol has been shown to reverse the ventricular remodeling, but other two drugs can block it, but the carvedilol is the one which has been shown to reverse ventricular remodeling. And what is the other drug which can reverse ventricular remodeling?
Mineralocorticoid receptor antagonist.
Not to my knowledge. ARNI has been shown to reverse the ventricular remodeling. So these two drugs have been different. What is the effect of ventricular remodeling on the normal myocardium?
Sir, normal myocardium is contractility increase, sir.
No. That is not the effect of ventricular remodeling. That's a compensatory phenomenon. Normal myocardium.
Increase in the size of the cells and hypercontractile.
No, that you already mentioned. Go and repeat it.
Okay,
What is the effect of dilatation of the heart on the Professor Taragan has already given you a clue that when the heart dilates, there is an increased stress on the myocardium. And when there is a stress, what is the compensatory mechanism of the heart?
Compensatory, sir.
How can the heart bring down the stress?
This RAS system get activated.
No, you tell us very simply, when the wall stress is increased.
Wall stress.
Yes.
What are the mechanisms by it decreases the wall stress? One, it can be diastolic wall stress or the systolic wall stress.
Yes.
Tell us at the sarcomere level. Tell us at the sarcomere level. What happens when the end diastolic volume is increased and the end diastolic pressures are increased? How does it get normalized? By addition of sarcomeres.
No. He's asking about the mechanism.
Series.
The hint is that there will be some kind of hypertrophy. Can you take the hint now?
Yeah, one is sarcomeres in series that increase the length of the myofibers. And hence the heart muscle increases in size, the LV-EDP would become normalized because the stress on each sarcomere becomes less. For pressure overload, for stress with pressure overload, they actually get deposited in parallel so that there is hypertrophy. Now, this is the basic mechanism how the myocardium brings down the myocardial stress, wall stress. Okay.
What is the formula for wall stress? Can you tell the formula?
Sir, Laplace law, sir, it is directly pressure, radius, and inversely proportional to thickness.
Okay, H is lower down, 2H, and on top is the pressure and the diameter or radius.
Yes.
So by increasing the thickness of the myocardium, so normal myocardium thickens. Those are the two important changes in the myocardium. The infarctal myocardium thins out, and the normal myocardium actually thickens. That is a hemodynamic change that usually takes place associated with ventricular remodeling. Okay. So here in a patient who has developed these symptoms, what are the things which crossed your mind? Why this patient has developed a progressive deterioration? One is ventricular remodeling. Two.
Like MI was 1.5 years back, and patient has become symptomatic 6 months back only.
Okay.
So once positive remodeling was started, then the systemic causes already we told like.
Maybe you can always think of on top of that you can think of ventricular aneurysm also. Aneurysm is something which can always cause the extra burden on the heart, because it behaves something like a mitral regurgitation. When the heart contracts, the aneurysmal segment dilates, blood gets into the aneurysmal segment, and when the heart dilates, the blood in the aneurysmal segment comes back to the heart. So it adds volume overload and also wastage of the pumping power of the heart. So ventricular aneurysm is the one thing that can actually deteriorate the condition of the patient. Of course, arrhythmias, atrial fibrillation should always be thought of. Mitral regurgitation should be thought of. And other associated conditions like anemia, thyrotoxicosis, which actually can cause patient to deteriorate, also should be on your mind. It may not be there, but that should be on your mind. Once in a while, you may get a patient who has become anemic and has become symptomatic, or you may get a patient who has got thyrotoxicosis and has become symptomatic. So that also should be in your mind.
We'll ask just one question to him. Suppose this patient religiously came to him after 6 weeks on a follow-up.
Yes.
What would he have done? What would be the things that you would address to see that this patient doesn't come into this stage?
Our initial, like for heart failure patients are like, because already late for revascularization now. First target is optimization of medical therapy. So we have to up titrate the doses of ACE inhibitor and other drugs it was taking and introduce.
When you said is optimization of the medications.
Second, second we can do is the exercise capacity we can assess, and lifestyle pieces we can give, sir. Then dietary advices we have to give.
All right. Now you see, you have got a patient who is 61-year-old who has 10 years of diabetes. You are not told about other risk factors like hypercholesterolemia, family history, and maybe even hypertension. Those things you are not told, but still, diabetes of 10 years means he is at risk with hyperglycemia or insulin resistance for nearly 20 years.
Yes.
What do you think his coronary system will be? Do you think it is all limited only
Mostly,
to
will be, sir, mostly like we are expecting some diffuse disease only.
Yeah, but that means you must address to whether this patient has multivessel coronary disease, and which you can probably address at 6 weeks, is it not? That's the time by which the left ventricular function would have normalized or maybe at the border of deterioration. So you should at that point maybe would like to get the anatomy of the coronary.
Yes. Decision regarding revascularization also we have to make.
In a patient with a triple vessel disease, if the patient is having a critical narrowing of a one vessel, how can the myocardium behave? Can there be a behavior of the myocardium to protect the myocardium from further damage?
Did not get, sir, like patient is having single vessel disease and
no, multivessel disease or single vessel disease with a very critical narrowing.
Okay.
What can happen to the myocardium? The myocardium, will it protect itself by doing something?
Long term, this decreased blood flow to myocardium might lead to hibernating state.
Okay, what is myocardial hibernation and what is stunning? What is the difference between these two?
Stunning is an acute phenomena when suddenly this blood supply to myocardium is decreased. Afterwards, the blood supply recovers, but the myocardium still is not functioning.
Okay,
that is
very good.
Phenomenon.
Very good. Hibernation?
Hibernation is like chronic ischemic state where this chronic decreased blood flow to myocardium is there. And then the myocardial function decreases, but there is still viability.
Contractile function?
Contractile function is decreased. On FDG uptake, it will be either normal or it might be increased also, like
okay.
Activity.
And what is the theory regarding ventricular remodeling mechanism?
I'm not sure. Like ventricular, I did not.
What is the mechanism? What is the proposed mechanism for the patient to develop ventricular remodeling? Oh, sorry, hibernation.
We discussed this.
Sir, hibernation is perfusion pressure is decreased. Resting perfusion pressure is decreased, sir, along with function.
No.
In stunning, sir, perfusion pressure is normal, but in hibernation, along with function, this perfusion pressure is also decreased, sir.
No, perfusion pressure is, of course, see, why do the patient develop ventricular hibernation? Why do the patient go in for hibernation?
Hibernation, protective mechanism.
It is a protective mechanism. Why, if the ventricle is contracting powerfully, what will happen to that myocardium?
More oxygen demand will be there.
More oxygen demand, but the patient can go in for infarction. So it is a nature's protection that the patient is going for ventricular hibernation. And what is the mechanism of ventricular hibernation? I think there are two theories. At the moment, I am not able to remember very well. One is related to potassium, and there is one more theory which actually explains the ventricular hibernation. You must read about that. Ventricular, what is the mechanism of ventricular hibernation? And on echocardiogram, how do you suspect ventricular hibernation?
This myocardium is like there is a decreased contractility, sir, but it's not thinned out.
No. The retained thickness with non-contractile myocardium should make you suspect that the patient may be, the myocardium may be hibernating. And these are the correct candidates for revascularization because these patients can completely recover over a period of time with the revascularization. If the revascularization is delayed, what can happen to the ventricular hibernating myocardium?
It might remain hibernating for very long periods, sir. Otherwise, slowly it might.
No, if it is remaining for hibernating for a long period, what are the pathological changes?
Slowly, sir, fibrosis will start happening.
The patient can develop fibrosis, and the total recovery may not be there. So when you find myocardium is hibernating, you must actually revascularize as quickly as possible. Otherwise, there can be fibrotic changes, progressive fibrotic changes, which can result in failure of recovery, complete recovery, may partially recover, but failure of complete recovery. So hibernation should not be allowed to continue indefinitely.
A couple of questions. The presenter said that there was no orthopnea for last 2 months. And then in the end, you said that patient is complaining of cough at night. So what is it?
Sir,
what does it mean that the patient? You said that the patient was having orthopnea for last 6 months, but for last 2 months there is no orthopnea. But last 2 months patient is having cough while lying down. What does that mean?
Sir, orthopnea, it may be because patient may be started on diuretics, so that orthopnea part may recover, sir. But this night cough, sometimes PND can cause of paroxysmal nocturnal dyspnea that awakes the patient.
So is it the history of nocturnal cough has to be more elaborate, whether it is immediately on lying down, when it will be equivalent to orthopnea. So one cannot say that if it is occurring only on lying down, one cannot say that patient is not orthopneic. And if it is occurring while the patient has gone to sleep, then it may be labeled as PNDs. Second thing is that how many times can you have PNDs in a night?
Only once.
Classically, PNDs happen once, twice, thrice, 4 times.
One episode only, sir. One episode, sir. That awake the patients. Then patient become anxious, sir. Then he may not go to the sleep after this first episode, sir.
So he remains awake after the episode of PND. He slept at 10. He got PND at 2. Then he will not sleep. Is it the history?
History, sir. It is given by, sir, this KGMC. We don't know the exact.
No, I'm asking you.
Yes, sir.
Whether so patient goes to sleep at 10.
Yes, sir.
He gets PND after, let's say, 3 or 4 hours. At 2 a.m. he gets up. Now, will he sleep the same night after 2 a.m. or not?
Not, sir. He will not sleep, sir.
Oh.
No, sir.
He may sleep, sir, but this REM sleep, no, because this PND develops in REM sleep also. So that REM sleep may not come. So patient may not develop PND.
Listen. What you mean to say is that when the patient in an episode of PND, when he gets up, he doesn't get sleep. Is it so? Is it the history that you get?
PND, sir, no, patient goes, sir, first he go to the sleep, sir. Then night 2-3 am he get up, sir.
Then he goes to sleep or not?
Then he will go to sleep, but sir, it will take, sir, 3-4 hours again to develop. No, sir. Then second episode will not occur, sir.
So why it will not occur next time after 3 hours? Why doesn't he have a PND again at 6 a.m. in the morning?
6 a.m. because of rapid eye RAM activity of sleep.
Something more. What is the mechanism of PND? And how it is relieved?
Sir, PND1 mechanism is that one of this fluid, it gets into the intravascular department, intravascular department, sir. And second, it is because of this
so intravascular compartment, it has come into intravascular compartment, patient gets up.
He gets.
Then why doesn't he have PND again? It's extremely rare to have PNDs twice. So what is happening at that time when he gets up? How is he relieved? There is natriuresis. So what you are doing is that you are perspiring, you are oral breathing, you are losing sweating, you are losing fluid.
Okay.
And that left ventricular end-diastolic pressure, which was raised by virtue of urination, by virtue of perspiring and sweating, your intravascular circulating volume will be reduced. So then when you go to sleep, there will not be enough intravascular volume to wake you up at late night. That is why rarely you have PNDs twice at night.
Okay.
Second, from the presenter, second question is, do you think that the patient's medical treatment is optimal now? You said that GDMT currently is optimal. Is it optimal or more than optimal? You are still continuing with DAPT. Is it usual that you continue DAPT after 18 months?
No, sir.
No, sir. So, no.
So you said it is DAPT.
Yes, sir.
GDMT is being continued. Isn't that?
Yes, sir. It
Okay.
was continued.
So do you think now you go back, if you have to go back on prior to discharge, what would you have done? 1 week, Dr. Tarkan asked you, but prior to discharge, you could have done something? Prior to discharge, risk stratification is important. The patient at that time, you should have risk stratified. There should be a risk stratification at the time of discharge, and definitely once he comes back. But even at the time of discharge, risk stratification and vocational advices must be given to him. Okay.
Just want to have one explanation regarding the paroxysmal nocturnal dyspnea. The mechanism of paroxysmal nocturnal dyspnea is actually a fluid shift. The extravascular fluid gets into the intravascular space. So the intravascular volume increases, and when the patient wakes up, sits up, there is some more sympathetic activity, the cardiac function improves, there is diuresis. The patient passes more urine, he feels comfortable, he lies down. When he lies down, there is no more fluid shift, because whatever is the fluid shift which would have been there has already happened. So next time when he goes to bed, there is no more fluid shift. And whatever is extra fluid which has come to the intravascular space, at least part of it is passed through the kidneys, and there is a diuretic effect. And also, as has been pointed out, perspiration and other things can actually bring down the intravascular volume artery. And as has been rightly discussed, paroxysmal nocturnal dyspnea is a one-time event, and usually at night subsequently there is no more episodes of paroxysmal nocturnal dyspnea, and very often the patient goes to bed within another 10 to 15 minutes. It is not 3 to 4 hours. About 15 to 20 minutes later, the patient feels comfortable and he usually goes to bed and he sleeps well.
So can I interrupt? I think we are a little behind schedule. So can we go to the physical findings now?
Yes, yes.
One last, Dr. Venugopal, one last question. What would you have told the patient if patient had asked you, what are the chances of my dying in coming 1 year at the time of discharge? And what would you have told the patient if the patient had asked, what is my chances of survival, let us say, not dying, That's a bad word to say. What are my chances of survival by 1 year? And then has it changed now? From now onwards, 1 year, has it changed? Who will answer?
So at that, because this patient it was not thrombolyzed, so we have calculated the TIMI risk score for anterior wall MI, sir. These are the 9 points. So on that basis, we can give the prognostic value.
Now, what would you? What I got? You got the question. Now, what would you tell him? What is his chances of survival now? From now onwards, 1 year.
Sir, score how much is the according to score, sir? That
you have the information now. Ejection fraction, let us say, remains 36%.
Okay, sir.
What would be his chances of survival per year? He is on all optimal therapies, and let us believe that he didn't have angina, so he doesn't have a revascularized myocardium. So, what do you think is his chance of survival, 1 year survival?
Sir, from Trivandrum Heart Failure Registry, 1 year mortality, although it was, I think, done on chronic heart failure, 1 year mortality is 30% now, sir.
So that is different. That patient is different. This patient is ischemic cardiomyopathy. And you know it is a single vessel disease. You have the information. He is on optimal medical therapy.
Yes.
So what is his chances? What is the control mortality in the latest trial, let's say DAPA-HF or whatever trial? What is the mortality of control arm? Or the best treated arm? What is the mortality? It has been shown by Professor Sethi beautifully.
Sir, in the tune of 10 to
12.
Correct. So that will be about 90 to 92% survival if you are having all the therapies.
Yes.
Can you hear me now? I think I was on mute all the time. Can you hear me? I'm Dr.
Yes.
Bhatt. Okay, no, we had in all this remodeling concepts which are very important. What the students should know is immediately following an infarction, before the process of remodeling, which occurs in a couple of days' time, starts in a couple of days' time. Two other things which we haven't discussed, you can go through that is infarct extension and infarct expansion. Those are the two immediate things that happen. Subsequently, the remodeling starts. And as Dr. Tarakan had said, remodeling is independent of further insults. And how much occurs in whom, and we have discussed those up. Remodeling, you should remember, is persistent and ongoing, continued compensatory mechanisms, which initially are adaptive, but later become non-adaptive. And so those are, so infarct expansion and extension you need to know. And the other is just one little question, between orthopnea and PND, which is worse for the patient?
Orthopnea is worse, sir. Orthopnea come in NVJ class 4, sir, because it comes immediately lying down, sir.
Yeah. Okay. So I think we can go on to the case presentation of the findings.
Just want to make a small comment. Actually, orthopnea is a symptom which is not specific for cardiovascular system. It can happen in patients with a respiratory illness. It can happen in patients with ascites. So orthopnea by itself, as far as the cardiovascular system is concerned, I would think that PND definitely indicates a left-sided disease. I agree that orthopnea is a major form of symptom of breathlessness, but you should be certain that it is purely cardiac and not related to any respiratory or any ascites in the abdomen. All those can also contribute to the symptom of orthopnea. But
how are orthopnea and PND scored? Yeah.
Can I just say PND is more specific for left heart disease?
Yes.
And orthopnea is more sensitive for the overall prognosis of left heart disease. I think
it's a more severe form of dysfunction, but you should be certain that there are no other contributing factors for orthopnea.
Yeah. That's right. It is sensitive, but may not be specific. Right. Shall we proceed?
Okay. The King's George people from Lucknow, can you present the case now and discuss?
Dr. Swati?
Swati?
Yes, sir.
Can you just present the physical findings?
Yes, sir. Coming to examination, sir.
Yes.
Yeah.
To general examination, patient conscious, cooperative, well-oriented to time, place, and person, thin build and sitting comfortably. Weight 78 kilograms, height 158 centimeters, BMI of 31.2.
Doctor, I am really surprised that he is 78 kilograms, 158 centimeters, and is thin. 158, 78 kilos means he should be obese.
Yes.
Okay, right.
Obese.
Okay, go ahead.
Go ahead.
Vitals, sir. Pulse 102 per minute in right radial artery, regular, normal in volume and character. No radio-radial delays and radio-frequency delay. Condition of vessel wall normal. All peripheral pulses palpable and bilaterally equal. Respiratory rate of 16 per minute, regular, with no use of accessory muscles of respiration. Temperature 98.3 degrees Fahrenheit. Blood pressure 110 by 62 millimeter of mercury, sitting position in right arm. No significant differences in pressure in all four limbs. JVP is raised 4 centimeter above sternal angle at 45 degrees. Amount 6 millimeter of mercury with prominent A wave with
No, what did you say? No. I just want a clarification. You said 4 centimeters above the sternal angle, 6 centimeters of mercury. What is that? What do you mean by that? 6 millimeters of mercury. What do you mean by that?
So 4 plus 5 from the midpoint of RA to sternal angle, 5 centimeter we added to 4 centimeter, amounts to 9 and then divided by 1.36, so 6, round off to 6 millimeter.
Oh, you are calculating what is the left atrial pressure by adding 9 centimeters and you are converting it.
Right atrial. Yes.
Okay.
Saturation on room air 98% in right upper limb and 99% in right lower limb.
Okay, this patient is having a prominent A wave. Can you tell me what are the mechanisms of prominent A wave in this patient and in this particular patient? In this particular patient, when you found a prominent A wave, what are the things which crossed your mind?
One is increased PA pressure, sir. Mean RA pressure is raised and because of pulmonary artery hypertension. Second is
that will take a lot of time because okay, right? Yes, that's not cannot be the most important reason. Yes.
Sir, we can think sir MR, ischemic MR in this patient.
Ischemic MR cannot give rise to a prominent A wave in the neck.
Increased filling pressures.
You mentioned JVP is raised. What's the normal RA mean pressure?
4 to 5.
It's a range.
4 to 6. 4 to 6.
So you think 6 millimeter mercury mean pressure in the RA is raised. Suppose you talk of pure hemodynamics. Suppose someone has a A wave of 12 and a V wave of 5 and a V wave. Which contributes more to the mean pressure, A wave or the V wave? And can you tell me why in the RA trace and the wedge pressure trace, there should be difference between the A and the V wave? It's the same blood volume, right?
Yes, sir.
So what contributes to the mean, A wave or the V wave?
V wave, sir. V wave.
Yeah. Why is it so? Because this is not a mathematical mean. I'm giving you a hint. When you talk of a mean pressure, it's an electronic mean. So why is V pressure V more V given, or why does V be represented more in mean pressure? It's the same blood volume, right?
R is more compliant, so it.
Okay, good.
Yeah. So basically any mean, it's the area under the curve, right? So compared to the A wave and the V wave, A, if you see, is always a sharp wave, isn't it? A V is more expansile. And so electronically, anything area under the curve being more is more represented in a mean, isn't it?
Yes.
Yeah, okay. So go ahead. So,
you are not answered my question. Now, what is the
Manjuran's question? A wave.
A wave. What is the reason for prominent A wave?
You think it's normal? After all, RA, the A wave is more prominent and 6 millimeter of mercury mean RA pressure. And do you think the sternum, this 5 centimeter below the sternal, the angular fluid, is a still valid phenomenon, valid thing to talk about? is that anatomically correct now that you have a lot of other evidences which has come in?
So current CT based.
Yeah, because CT based evidence which is coming in because
there has been studies which have shown that it varies from up 5 centimeters up to 8 to 9 centimeters.
But unfortunately, at your DM level, JVP is going to be an Achilles heel for you. So you better know all the nuances of JVP.
See, when you said prominent A wave, what was the height of the wave in the neck? What was the height of the wave in the neck? Sorry, what was the height of the A wave in the neck? The one mechanism in which there can be prominent A wave in this patient could be if there is a septal infarction, it can actually cause bulging into the right ventricle, something like a Bernheim effect. Bernheim, of course, described for hypertrophied myocardium, but here the thinned out the interventricular septum can actually bulge into the right ventricle and encroach on the cavity of the right ventricle, resulting in a prominent A wave. So in a patient with a prominent A wave in an anterior myocardial infarction, you can always carefully look for, or you can interpret thinking that probably the interventricular septum is scarred and is bulging into the right ventricle.
Yes, Swati, when you present cases, remember some examiner are going to note down every small point that you say. What do you mean by saying the condition of vessel wall is normal? What is your interpretation? What did you have in mind? You can't just write down and not know what you're writing down. Yes. So what is condition of vessel wall refer to here for you, which you felt to put it down there?
Yes, sir. The arteriosclerosis, that is the calcification in the vessel.
Is it atherosclerosis?
Arteriosclerosis.
No, that's what a rolling down of the, yeah. So is it the same as, is it the same as atherosclerosis, for example? You see, what causes the thickness or palpability of the radial artery is, what causes that? Something in the media, right? You're not seeing any endothelial testing, which is, so here, basically, what is Monckeberg sclerosis? Yeah, the two are different. You see, the coronary, that's the logic for the coronary calcium score. You see, coronary arteries are one where dystrophic calcification does not occur. And that's why in the, it's considered a sine qua non for coronary artery disease or atherosclerosis. While in the radial artery, for example, a thickened palpable radial artery need not correspond to atherosclerosis. I mean, so you should just know when you talk of condition of the vessel wall, that's what you are basically, if you're saying that in a diabetic who has no other signs of atherosclerosis, a palpable radial may not necessarily mean atherosclerosis.
How do you test for palpability of the radial artery? How did you test in this patient? Swati?
Yes, sir. By using 3 fingers with the middle finger rolling of the artery by the middle finger, we roll the artery and test for the vessel wall palpability, sir.
Actually, you can do something known as Osler's maneuver. That will be more accurate. But what is Osler's maneuver? Osler's maneuver is you obliterate the brachial artery and then palpate the radial pulse.
Yes, sir. If it is palpable, then
if the radial pulse is, because an artery is palpable only if there is a pulse. But if the pulse is obliterated and still artery is palpable, it is a problem.
Raise the sphygmomanometer beyond the systolic pressure.
I think it's easy to do. You can even do with your hand obstruction that the brachial artery can be completely blocked, and then you can get the radial artery rolled over the radius. Okay, right. Go ahead. So I think A-wave prominence, you must always think of the possibility of interventricular septum bulging into the RV, giving rise to the prominent A-wave in the neck. Okay, go ahead, Swati.
Yes, sir.
Yeah.
Here in conjunctival, orodental hygiene is normal. No clubbing, icterus, cyanosis, pedal edema, and lymphadenopathy. No features of infective endocarditis. Musculoskeletal system examination is normal. Serious examination, inspection and palpation. Chest is symmetrical. Chest is symmetrical. No chest wall deformities. Trachea central and spine is straight. No visible scar mark, dilated veins and sinuses. No visible pulsations over precordium and epigastric lesion. Apex is in left 6th intercostal space. 2 centimeter lateral to mid-clavicular line. Apical impulse hyperdynamic in nature, linear contraction. Palpable S3 present at apex. Liver palpable just below the coastal margin. Liver span is 12 centimeter. No parasternal impulse and P2 is not confirmed.
Okay, I want to ask you 2 questions. How will you look for ventricular aneurysm on palpating the precordium?
Sir, the apex will be present in more than one space, and it will be more diffuse. And the above impulse will be medial to the.
Where do you palpate to detect ventricular aneurysm? Where do you palpate to detect ventricular aneurysm, and how do you do it?
Above and medial.
Yeah, you palpate one space above the apical impulse, and how do you do it?
In the lateral, left lateral position.
No, you don't have to go to left lateral and all. In the patient lying flat, you can do it if it is palpable. You should use actually 2 fingers.
Yes,
actually, you can use even
put in different spaces.
Two hands you can use. And then if you find that the discoronous impulse between the apical impulse and the impulse one space above that, that is more suggestive of ventricular aneurysm. And another point, when there is a palpable sound, do you think there is more likely to be an S3 or an S4? It's extremely difficult to tell in this patient because S3 or S4, because you said the heart rate is 102 per minute. Can it be, if you are palpating the S3, can it be summation effect, summation gallop? Is it S3 or S4 that you are palpating? More often it is S4 which is more palpable than S3. And you should be very careful in committing S3. And what is summation gallop?
S3 and S4 together.
On electrocardiogram, how can you suspect summation gallop? By looking at the electrocardiogram, can you suspect summation gallop? What will be the electrocardiographic finding which will tell you that, yes, this patient can have summation gallop? You said S3 and S4 should occur together. So what should be the electrocardiographic evidence? If there is a P wave occurring immediately after the T wave, there is a good possibility that S3 and S4 are occurring together, and you may be able to get a summation gallop. Okay. Right. I think we'll look at the auscultatory finding to make out whether it's S3 or S4. I would have thought that palpable things are more S4 than an S3. Okay, right. Yes, go ahead.
Percussion, right heart border corresponds to right border of sternum and left heart border corresponds to apex, and pulmonary area is resonant on percussion. Auscultation, S1 normal, S2 normal, A2 and P2 with normal respiratory variation, LV-S3 present, no S4, no other added sound and no audible murmur.
No, before that,
a little clarification.
Did you carefully look for this patient has got severe LV dysfunction? You are saying S1 is normal, A2, P2 is normal. There is these are features you have to look for. Paradoxical splitting of the second heart sound. Did you carefully look for paradoxical splitting?
Yes, sir. In the standing position as well, but
even in the lying position, did you carefully look for? Okay. Can you tell me 5 or 6 conditions where there can be paradoxical splitting other than the usual left bundle branch block, LV aortic stenosis, and LV dysfunction? These 3 are out. You tell me other 3.
Yeah, and I just wanted to maybe make a point that there should be no disparity between your presentations. Within your presentation, you're telling in a hyperdynamic impulse, and now you find there is no reason for a hyperdynamic impulse. We thought there may be mitral regurgitation or even a post mechanical VSD, but none of it is there. So I think it is not correct to tell hyperdynamic impulse. Be careful. It may actually be a dyskinetic apex and maybe the juxtapical area. I mean, that would be the most likely thing. Be careful. Don't have discordance between your physical findings. That's very, that's not acceptable. That's the only thing I would like to point out. And I think you should be a little more careful to make sure that there's no pulmonary hypertension, because this patient has been having orthopnea PNDs. pulmonary hypertension, pulmonary venous and pulmonary artery hypertension usually comes. And that might explain also the small prominence of the JVP where the A waves are little formed.
Yes.
When you listen to third heart sound, loud third heart sound in this situation, what would be the PCW? When you are listening in heart failure, when you are listening a third heart sound, what do you think would be the PCW at that time? I am extending that what Dr. Tarkan is saying, because this is a very sensitive, I should say specific, not sensitive, specific for left ventricular end diastolic pressure of more than 18, definitely, and probably more than 22. So your venous pressure mean becomes 22. So in that situation, you are safe to say that he is having pulmonary venous hypertension. And then that would be the pulmonary arterial diastolic pressure. That means your systolic pressure has to be more than, by usual 2/3, 1/3 ratio, it should be somewhere around 40. So he will have a P2. Sometimes the intellectual dishonesty is permitted. Sometimes, but that needs understanding of the hemodynamics.
Yeah,
so P2.
In an elderly, LVS3 is absolutely pathological. In the absence of MR, it becomes much worse as a matter of left ventricular dysfunction. If there was MR, we would have given a consideration that it may be an S3 with diastolic normal.
Because of MR, but here there is no other explanation for third heart sound. So you have, and you didn't. Now you can't say that it is. You said only LVS3. You specified. If you would not have specified, then you would have left us some margin that maybe the right ventricular failure is there because of associated right ventricular something, and maybe there is pulmonary venous pressure is not traced. But here you have committed, so you have to come back in your. Remember to include venous hypertension in your diagnosis, definitely.
I think it's correct. It's a good point.
So, do you think that this patient still on echocardiogram can have mitral regurgitation?
Yes, sir.
How is the mitral regurgitation murmur detected? Which is the murmur which very often, or maybe that it may not be audible, but you will be able to pick up in the echocardiogram? Actually, the wall hugging jets, the ones which are very easily audible, the mitral valve prolapse, rheumatic heart disease, which are mostly wall hugging jets or mitral regurgitation, which are usually loud and easily audible. But when the jet is to the central part of the left atrium, sometimes the murmur may not be audible. You may detect a good mitral regurgitation on echocardiographic examination, and on clinical examination, you may not be able to pick up a easily audible murmur. So still there is a possibility that echo may show this patient may be having mitral regurgitation because of the size of the heart and valve.
Yeah,
This
that's
Swati,
certainly.
in this second
Echocardiation
sound,
is likely to be there.
yeah, the second sound, Swati, is very important when you talk of P2 and we expect pulmonary artery hypertension. In adults, sometimes, in these acquired sort of thing, you may not actually find left parasternal heave as much because, it's unlike mitral, rheumatic or congenital heart diseases. In these, evidence of pulmonary artery hypertension is more subtle on the bedside, indirectly governed by the symptoms that Dr. Dwivedi said. If a patient has PND or orthopnea, you're likely to have high wedge pressures. But tell me, what are the subtle findings that you look for? When do you say P2 is, or when there's pulmonary artery hypertension in this patient minus LPSH? After all, you're only going by LPSH, absence of tricuspid regurg, and other things to say that pulmonary artery hypertension. Here, A wave could have pointed to a pulmonary artery hypertension. But
actually,
about P2, what is the subtle things that you'll say that the patient has PAH? What happens to the A2P2 in most forms of congestive heart failure? You see, the split behaves depending on the underlying disease also, as you know. But in general, patients with PAH, how does the split behave? Is it wide? Is it wide? Does it narrow? Does it become
narrow, sir?
So narrow is also normal with split that way, technically speaking, but it narrows. But more importantly, when do you therefore say suppose this, I say with these findings, he has pulmonary artery hypertension also. You see, P2, where all is it heard? normally where do you hear P2?
In the left second intercostal.
Yeah, suppose if you hear the P2 also 1 or 2 spaces down,
Yes.
that itself could be an evidence of P2 being loud. Otherwise, loudness is very subjective, no?
Yes.
So to say that the P2 is loud, I think.
Does it go towards apex?
Yeah, or if it's heard beyond the pulmonary area, right? So these are subtle things which intellectual dishonesty you could use. And no, so long as you see an exam, remember, so long as your hemodynamic explanation is okay, you can always get away with these things, you know, which after all we do realize the limitations of physical exam. But so long as you know what you're talking about, these points may not be held against you. But hyperdynamic apex, no audible MR, all those little peculiar.
Swati, you can say that third heart sound not is 100% specific. And if you go to the literature, at the most it is 80-85%. So you can have a PCW of more than 80. You can answer that way also. That S3 doesn't necessarily tell you. It correlates. You can come out of that also, but provided you have read about these specificities of these clinical signs, how far they can be specific and sensitive.
Yeah, and then
actually, so
just staying on hemodynamics, you see, as Dr. Dwivedi mentioned, you have to have high filling pressures for an S3. And that's why be careful if you say that the heart rate is 70 and you're hearing a S3. Usually patients with high wedge pressures will not have heart rate of 70. So, you know, normally one hardly ever sees an S3 in a patient with a pulse rate of 60 or 70 in a well-controlled heart failure, right? So S3 is very important to know that it represents high wedge pressures.
I would, yes, agree, but just one bit that once the compensatory mechanisms come into action, the resting heart rate of patients who participate in these trials, if you come, despite being class 2 and class 3, the average heart rate rarely goes more than 100. They are generally in the range of 80s, 90s, whether it is a consensus trial or...
Yeah, that's what, but if you see clinically, when these patients are well compensated, not in heart failure, heart rate of 70, you hardly find S3. I mean, that
is correct.
Yeah.
Usually, that I think I will agree with Dr. Anil, but because usually when the S3 is there, usually there will be some degree of tachycardia. That's the usual phenomenon. See, about the second sound, I want to tell you that in a patient with heart failure, there are many factors which actually influence the pattern of second sound split. The LV dysfunction will make A2 delayed. Mitral regurgitation will make the A2 early. The patient is having pulmonary artery hypertension will make P2 early. So there are many factors which actually interplay, and ultimately the pattern of A2 P2 is depending upon all these factors. So you can get paradoxical splitting, maybe wide splitting, maybe close splitting. All these things can happen because of the various factors which can actually influence the A2 P2 relationship. So
and maybe fixed splitting also in heart failure.
So I think whatever you describe, you have got enough points to defend yourself if you know the hemodynamics and also the effect of various lesions on A2 P2 relationship.
Can we go forward?
Yeah. Okay. Right.
Dr. Swati.
Some examinations of respiratory systems, bilateral air entry present equal, vesicular breath sounds not, no additional sounds. For abdomen, liver not palpable, total liver span is 12 centimeters. No splenomegaly, no pre-fluid, CNS examination within normal levels.
So nothing to do with the cardiovascular system. As a third year student, can you go to the next one? It is not correct to use the word air entry. You should say that breath sounds, because you are not measuring the air, but you are getting an idea about the breath sound. Right? Yes, that's nothing to do with the cardiovascular system.
Okay. Go to the investigations, basic investigations.
So ECG, sir.
Yeah.
Now, before ECG, you should put a provisional diagnosis. Then we'll go to ECG and X-ray. Give a provisional diagnosis, then we'll go ahead. So this patient has got a previous myocardial infarction. There is a cardiac enlargement. So all put together, you have to give a provisional diagnosis and then go to the electrocardiogram.
Yes, sir. So the provisional diagnosis is patient of ischemic cardiomyopathy with history of anterior wall MI 18 months back.
You can put it as coronary artery disease, anterior myocardial infarction past 18 months ago. Then what has happened now? Do you think the patient has developed a ventricular remodeling?
Yes, sir. With development of cardiomegaly, sir.
Okay, the patient might have developed ventricular remodeling because there is an apex beat is down and out. Yes. Is a normal sinus rhythm? Is he in heart failure?
Normal sinus rhythm with NYHA class 3 to 4. Presently in NYHA class 3 on guideline directed medical therapy.
Okay. Do you think that you have to mention including heart failure?
Yes,
Because there is a third heart sound. You can include that also as part of your diagnosis. If you think that third heart sound can indicate there is some degree of LV dysfunction, elevated left ventricular and diastolic pressure, you may put that at least LV dysfunction can be included. Okay, right. Yes.
With the mild PAH, sir, and
from your clinical examination, why did you diagnose PAH? You are not mentioned there is parasternal lift is not there.
Are you correcting yourself?
There is from your clinical examination, you cannot say that the patient is having PAH unless you have mentioned.
After the discussion, sir, I would like to.
You would like to change. Okay, right. Okay.
Okay.
You want to say, satisfy the clients. Very good.
Pulmonary venous hypertension, be careful. What is the grade that you are talking about? Be careful.
Okay.
Okay, right. Go ahead.
Investigations.
The ECG. So we have this 12 lead ECG with normal sinus rhythm with left axis deviation with the LBBB pattern with.
Wrong. Why did you say left axis deviation?
Why did you say left axis? Please be specific about the axis. You know, your DM
Where is left axis deviation?
You have to be very specific. How much is
normal axis, sir? Yes, sir.
How much is axis? Now that you're getting into trouble.
Yes, sir. Mean QRS axis is around 60, sir.
No, how can that be 6? That's why you get into trouble. You see, axis, you should be, there's several ways you can calculate axis, but you should be clear. This is, you see, close to equiphasic and lead 3. So rest are all normally inclined. So where would be the axis be?
Yeah.
That's important. You see, I find that a lot of students today are not, I mean, do you think axis is important? Let's come to that. How is axis important? Do you think it's relevant, irrelevant?
Yes, sir. It was
like in this patient, how would axis be, or this, or just if I was to show you this ECG, why is the knowledge of axis needed today?
Sir,
in general, can you tell me?
Towards left suggests more diffuse disease, sir.
You see, in terms of, I mean, so first, of course, you need to brush up on axis calculation because you don't have time at the exam, and you just can't say normal axis, left axis. You have to be specific. So this is not yeah.
Is it
so
plus near what?
In this patient, axis is plus or negative or minus? Is it on the
right inferior, isn't it?
Or in the lower left?
Plus 90, sir. Plus 90.
Just a minute. Just a minute. He said that lead 3 is equiphasic. So it has to be perpendicular to that.
Plus 30.
It will be somewhere around plus 30, isn't that?
Yeah, it is. If you think that lead 3 is slightly negative, it should be between plus 30 and plus 0. Maybe with plus 30 should be all right.
At least you should come that is somewhere around plus 30.
Yeah, yeah. I think I agree with you. Yes.
Yeah. Now go.
Okay.
Don't go to LBB first. Go as simple. PR interval normal, atrial enlargement. Then
is there an atrial enlargement, Swati?
No, sir.
No, say that.
Mention that.
Coming to chamber enlargement, sir. No LA enlargement and RA enlargement signs. No LH.
Conduction abnormality.
To conduction abnormality, that is left bundle branch block pattern, sir.
Yeah.
And something is unusual in the left bundle branch block?
Really?
Is it simple left bundle branch block or something unusual? You can't comment on ventricular hypertrophy here. But is there something unusual in the bundle branch block? What about the secondary T wave changes? On V4, V5, they are on the same side. T wave is upright.
T wave is upright.
Unusual. You should have expected a downright T waves here.
Yes.
Okay. What else?
When you comment on LBP, left bundle branch block, are all left bundle branch blocks similar? There's some hint in this. Everything LBB is the same electrophysiologically. What is LBB? You see, can you see something else here? Do you see a little notch on the R wave where V4, I can see an AVL, lead 1.
One and AVL.
What does that signify? Like, what is Schwartz criteria in left bundle branch blocks? Like, these are relevant because tomorrow, if you're going to choose a patient for CRT, for any patient, you know, they are non-responders, right? And that's because the LBB is a wide spectrum. Not all LBBs are similar. So can you tell me the electrophysiology of LBB? What does this notch represent and why this notch suggests that, of course, here the QRS is not so broad, but a good broad QRS with a notch, one AVL or the lateral leads is one of the predictors of response to CRT therapy. So are you aware of EP in electrophysiology in LBB? In left bundle branch block, what is the maximum conduction delay? Where does it occur? Intraseptal conduction times, how much is it before the bundle is, or before the interventricular septum is traversed and emerges into the left ventricle? So just to give that hint, that is what tells you the, so that's about, if I remember correct, it's 50 to 70 milliseconds. So the,
which one are you saying, Anil, which one are you saying?
The notch on the one AVL, or here you can see something on the V4. You see, that is supposed to represent the Schwartz criteria for LBB responsiveness, and that occurs, that notch is actually notch for the other upstroke or the other limb of the QRS is supposed to represent the time traversed within the interventricular septum to emerge on the LV side for the impulse.
Usually it is said that if the duration of the bundle branch is the duration of the QRS is equal to or more than 150, that is a definite indication for.
That's right. Within that also you have this criteria, which is very, very, I mean, most likely that they'll respond. Anyway, Swati, so here
I don't think there is a, I don't agree that there is a left bundle branch block, because
that's what QRS is not so broad, but
not
maybe
broad. I don't think it's left bundle branch block. I don't agree with that.
Maybe 0.13,
it's only
something
0.1.
like that.
It's only 2.5 divisions, and there is no evidence of a left bundle branch block here.
Okay.
Oh.
Okay, next.
Go ahead.
Go to the next.
Swati, can this patient have a summation gallop?
Yes. No, sir.
The P is very much away from the T wave, so you cannot have a summation gallop here. Okay, right? Yes, go ahead. X-ray.
So X-ray chest PA view with the slight rotation towards the left, with the normal situs, with cardiomegaly, with the cardiomegaly, LV type of apex, with the
how do you say that an X-ray chest, the apex is LV type, RV type, normal? What is it? How do you make out?
Yes, sir. The RV type of apex is more upturned, sir.
Okay.
And LV type of apex is it is towards inferior and towards the diaphragm. Yes, sir.
No, actually, it should dip below the. Actually, the RV apex is upturned, and there is an acute angle between the cardiac cillhead and the diaphragm.
Diaphragm.
In LV type of apex, it should dip down. You should find that the apex is dipping down the diaphragm, and then you are sure that it's an LV type. Here, I will agree with you that it is an LV type of apex, but it's not very classical. I agree with you that it is LV type of apex, and the angle between the cardiac cillhead and the diaphragm will be an obtuse angle.
Yes.
Other one is an acute angle, Here it is an obtuse angle. So I agree with you that this is more of an LV type, but classically it should dip down below the diaphragm. Okay, right.
Coming to lung field, sir, there are signs of pulmonary venous hypertension and pulmonary arterial hypertension as well.
What is the difference of pulmonary arterial hypertension?
Sir, this right lower descending artery seems to be dilated, although I have not measured it. But
no. I think if the vessels can be easily traced to the periphery, I will be very careful in commenting that there is definitely pulmonary arterial hypertension. Because of the pulmonary venous hypertension, there can be slight passive elevation, but no significant pulmonary arterial hypertension because the peripheral vessels are very clearly seen here. So unlikely that there is a significant pulmonary arterial hypertension.
yes.
Okay, right, go ahead.
Any curly lines you see? Just enumerate the types of curly line and which is most specific for pulmonary venous hypertension.
There are 3 types of curly line. Curly B, A, B, C. The B lines are seen at basis and they are seen at the periphery, perpendicular to the pleural surface. They are small, horizontal, and suggestive of interlobular edema. And curly C lines are also seen at basis.
And what are C?
Yes, sir. C lines
What
are
is
also
C?
seen at
C.
basis. They're end
No,
on
what are those? They are
end
end on
of
B.
curly B line. Yes, sir.
End on of B, right? And of A, B, C, which is most specific? Like you can get some of these which are due to just septal fibrosis or scarring due to non-pulmonary venous hypertension, right? So of these, which are most specific for pulmonary venous hypertension?
So, curly B lines, not sure.
Yeah.
The advantage of curly B lines are, as you rightly said, in the lower portion of the lung and is peripheral, it can be easily seen. A and B, sometimes it is mixed with vascular shadow and very often it is difficult to pick up also. So actually B is the one which is usually, we can be easily picked up, which is peripheral, which is horizontal, and lower part of the hilum where there are lower part of the lung shadow where there are not much of vascularity, and you will be able to pick up the B lines much more easily than other 2 lines.
Is the LV contour normal over here or rather not LV, the upper border of the left ventricle below the pulmonary artery? Is that contour normal? Yeah, that point.
Yes, sir. It is more outward, sir. Yes, sir. It's not normal. It should have been concave.
Yeah, it's just a descriptive finding. It may or may not support your finding of a displaced apex and old MI, but that's a finding. Certainly, it's a little bulged over there, right?
But not the classical aneurysm. Classical aneurysm.
No, it is not. No, it's not. It's just that.
It could be, but not the classical one.
Yeah.
Okay, right. Yes.
Sir, apical 4-chamber view of 2D echo showing enlargement of LV and LA with hypokinesia in the septal and anteroseptal and anterolateral wall and apex. With non-dilated RA and RV.
Is the LV encroaching onto the RV?
Yes, sir. Yes, sir. Septum is.
Do you think that there is a non-compaction? How do you diagnose non-compaction?
Sir, multiple trabecules and thickness and the ratio of compacted to non-compacted myocardium, sir.
What is the ratio? Do you measure the ratio in systole or diastole? And what is the ratio by echocardiography? What is the ratio by MRI? What is the difference?
Basically more than 0.3, sir. Jenny's criteria.
Yeah, what is it? What is the criteria? Is there a difference between the MRI criteria and the echocardiography criteria? And what is the criteria? Is it, do you measure during systole, diastole, in which ways? Non-compacted to a compacted region. In echocardiography, it should be 2:1. For MRI, it is actually 1:1.
NC to C, yes, a non-compacted to compacted.
Yeah, the non-compacted should be more than the compacted, while MRI usually they look for 1:1. And usually it is actually the criteria were described both during and systole and diastole, but now it is mostly we look at during diastole. Okay, go ahead. Yeah, there is a suspicion that there is whether there is some degree of non-compaction, or can it be a clot? If it is a clot, how will you make it out? Is an organized clot at apex? Swati, can this be an organized clot? Do you think that there is some organized clot at the apex of the LV? Are you there? Are you hearing me?
Yes, sir. Yes, sir. Yes, sir. I'm here.
But I'm not.
Can you definitely say that there may be a clot? What else would you do to say that it may be a clot?
Changing the contrast enhancements of the echo.
Edge enhancement.
Edge enhancement.
And also you can look at actually a short axis view of the apex also. You can go and do a short axis view of the apex, and sometimes you may be able to pick up the clot much better in the short axis view of the apex, and look for the other apex can be looked at from the parasternal long axis view, short axis view, and also two-chamber view, and make certain that the apex is free of clot. So you can do that, or you can even do a contrast echo, and contrast echo will delineate the clot very easily without any problem. But even without that, you may be able to get a good idea by looking at all the views carefully at the apex.
Can we go through the different echo views, sir? Because we are having a shortage of time.
Yeah. I think yes, that's right.
Already 8:40. So can we have the different echo?
Do you think that this patient may be having, Swati, do you think this patient is having aneurysm, or you are surprised to see the echo?
That's no aneurysm.
I'm surprised to see the preserved thickness of the wall, sir. One and
Wall means which wall you are talking about?
the septum, sir, and
Septum. The septum is not that thin as you expected it to be.
No, it's not thin.
Because the clinical signs are telling you that this is a cardiomegaly, and you doubted about the presence of aneurysm. But
Yes.
here, definitely the myocardium that you are seeing in apical four-chamber or parasternal, definitely the proximal portion and the whole lateral wall is not dyskinetic, nor in apical four-chamber were you seeing dyskinesia. So the whole thing is just a remodeling rather than any aneurysm in this echo.
So what might have happened, Swati, in this patient, what might have happened? He might have had a spontaneous reperfusion, because he was received thrombolytic therapy, nothing. And so he might have developed a spontaneous reperfusion. And also in the electrocardiogram also, there is no prominent Q waves. Actually, he has got an R wave even in V1, V2, V3, and of course there is a small Q in V4, but there is no pathological Q seen in the electrocardiogram. Okay, show all the views so that we can go for the management part also quickly.
short axis view, parasternal short axis view at the mid-papillary or valve level, sir.
In fact, in this view, the whole septum is contracting very nicely.
Yeah, it is actually LV function is much more than.
So what do you think? What was the ejection fraction now?
When
you examined the patient,
Yes.
that was the old value of 35%. What is now?
It's a 32%, sir.
It doesn't certainly look like 32 now.
Really looks much better. It's not so Dwivedi. I also agree that it looks much better than 30%.
Much better. You can see the thickening of the myocardium, the septum.
But the mode shows a poor LV function.
Can you go back to the Doppler signal? The forward Doppler flow, mitral flow. What is it telling you? What did you calculate?
Yes, sir. E by A ratio I calculated. It is 2.74.
No, what else should you calculate? Which is the most specific for that? You are trying to see whether there is a dysfunction or PCW calculation you want to do by this.
By E prime.
How will you do this?
Using E by E prime, sir.
No, in this.
Yes.
It is just mitral flow which is there. What will you see?
Deceleration time, sir.
So what is the, did you measure that? It is more sensitive than E by E dash,
Yes,
right?
Can I just
So
make
what
a point here? Can I make a point here?
Yeah.
E and A are fused. I think this is the E and this is the A. And here is that, see, these are the closure lines. I don't think this is E and A is this. No, I don't think so. Valve closures are probably here. I think it's
E is far away. E is away. The PR interval is not that big. E is this one. And A is this one and E is this.
Maybe.
Yes. So this is a, now what is the acceleration time that you measured here and what is the cutoff value to say that the PCW is more than 20?
Less than 140.
ESC says 130. So that is very sensitive and very specific also, more than 80%, right? And what was your E by E dash here?
Have you calculated E prime?
Yes, sir. I measured E prime, sir.
And what is the ratio? What is the normal? What is subnormal? What is the value? What is the interpretation of E prime?
So E by E prime was 12, sir.
12. So it is. And then I would have seen the contractility here. I would have gone to the strain also at the annulus, because the LV contractility at the base appears to be very good. So I would be keen to see what is the ventricular strain, and I'm probably surprised by the ejection fraction. There is a bundle branch block also, so maybe that what you are calculating as the ejection fraction may not be totally, that may not be representative of what you are doing because of LVB. It underestimates the ejection fraction by echocardiogram. But that is taken care of by the longitudinal strain.
But if you look at the, can you show me the M mode of the LV? That shows significant LV dysfunction. See, it shows.
It does.
The significant LV dysfunction. So I think the ejection fraction of about 30 or 35, I would consider that maybe normal, maybe correct. Because if you do it correctly by the biplane or by any technique, I think there is a significant reduction in the ejection fraction. By looking at the M mode, I will consider that it should be 30, 35, definitely less than 40.
Very important point.
Okay. Yes, because the E septal distance is very huge, more than one centimeter. The mitral valve is not opening completely. Okay, right? Yes. Yeah, ejection fraction 30%. But of course, ejection fraction you should do by biplane and not by M mode. M mode is not the correct one to do, because nowadays everybody recommends that it has to be done by biplane. Okay, go ahead, Swati. So you have to come to a diagnosis. Have you got any other further diagnosis here? And then is there a coronary angiogram? Then we should look at that also.
You don't have the Doppler, isn't it? Tissue Doppler? No. Okay, go ahead.
Final diagnosis, sir. Coronary artery disease. I would like to change it, sir. Coronary artery disease with the ischemic cardiomyopathy, severe LV dysfunction, ejection fraction of 30%, with mild mitral regurgitation and mild tricuspid regurgitation, with the mild PAH, PVH, and NYHA functional class 2 to 3, presently in class 3, and with normal sinus rhythm.
Swati, here, now that you have seen the echo and seen the ECG, the evidence of an old MI is not very convincing. Now, what if I say that when a patient came to you the first time, it was about 2 weeks after the index admission somewhere else, right? So in presence of LBP with tachycardia and heart failure, you think the anterior MI was misdiagnosed in presence of LBP because your septum and all echo is all preserved. It doesn't look like a old MI. So how sure are we here, or are you here, that the patient has had anterior MI? Because one is now, of course, the initial diagnosis of MI was not yours, was you just followed up that with a previous diagnosis 2 weeks ago before the patient came to you. What if I now say the patient has a dilated cardiomyopathy where CAD has to be ruled out? Because to say that there is a CAD old anterior MI, your echo doesn't bear it out.
And also it could be that it may be actually diabetic cardiomyopathy also.
That's what I'm saying is, so never go by known case of anterior, never known, there's nothing known. Avoid that trap. So unless of course you have because you see with LBP, if they get into pulmonary edema, heart failure, the tachycardia, someone may erroneously diagnose anterior MI. And so at that time, unless you have, enzymes to back it and all, you really don't know. You now, of course, need to do further tests.
Do you have a prior ECG at that time, or the discharge card available at that time?
Yes, sir. Discharge card was available, which mentioned the QS patterns in V1 to V4.
And was there a mention of LBB, or there was no LBB at that time?
No LBB.
Can we call this LBB? Because I still find that the duration of the QRS is only 0.1. So can we call it as an LBBB? I don't agree with that, because the duration of the QRS is only 0.1. And we cannot call it as LBB. LBB, at least it should be 120 milliseconds.
You measured QRS. What was it, Swati?
Sir, it was...
Did you measure the QRS?
110, yes, sir.
100?
110 milliseconds, not...
When I looked at I found it is 2.5. So I did not know whether it is, can we call it as LBBB? Okay, I think because of the background of diabetes, I would still go in for your diagnosis of coronary artery disease and ischemic cardiomyopathy. Of course, other differential diagnoses also will be kept in mind, but I will definitely entertain the diagnosis of coronary artery disease, which is much more frequent. He has got a background. And was he a smoker also?
No, he was not.
He was not a smoker.
Non-smoker, non-tobacco.
And for the initial history, did he give a history of a cardiac pain, which was suggestive of acute myocardial infarction?
Yes, sir. Yes, sir.
So all put together, I would agree with your diagnosis. That would be the diagnosis. But I will definitely, as pointed out, I think we have to keep our mind open, and the possibility of a non-ischemic problem like cardiomyopathy also can be discussed in the examination.
How will you proceed now?
We'll discuss about this summing when there is a summing up of this case in the take-home messages. So can we move forward to any further investigations if it is done, or otherwise we can stop?
Yeah, at least coronary angiogram. You can tell us the coronary angiogram so that.
Coronary angiogram, I think, will be a complete. That will give us the diagnosis also.
Yeah, I think no more discussions. Now let us come to the more concrete.
Correct.
Yeah.
Correct.
Is there a coronary angiogram?
Is there an angiogram available, Swati?
I think then we can have a discussion.
When we can have a discussion. Yeah.
Pravesh to sum up the case, sir. If the angiogram is not available, then Dr. Pravesh, I think, is presenting the take-home messages from this case.
Go ahead.
Yes. Dr. Pravesh, we are seeing slides.
Yeah. So, a very good evening to everyone, and I feel honored actually to be in presence of such great examiners and teachers. My job is pretty simple, to sum up whatever we have learned so far. So let's, without wasting time, because we are already quite late. So I'll just start with what are the take-home messages. I'll start with first what Dr. Dixit summed up, and then I'll come to examination. But before that, I have a couple of slides that because there were certain different definitions used in ESC and ACC, there was always a need to have a universal definition. So there are certain changes in definition and classification of heart failure. So I brought this slide. This is a joint venture by American, European, and Japanese heart failure associations. So they have reached a consensus that the definition of heart failure would be a clinical syndrome with current or prior symptoms or signs caused by structural and a functional cardiac abnormality. And it should be corroborated by at least one of the following, either elevated biochemical markers or objective evidence of cardiogenic, pulmonary, or systemic congestion. These may be visible either by X-ray, imaging like echo, or maybe invasive catheterization. You can go and directly measure the pressures, can gauge the amount of congestion. And this can be either at rest or maybe at exercise. So now we have a universal definition of heart failure, exactly as we had earlier the universal definition of MI. There are certain changes in stages of heart failure as well. Earlier it used to be stage A, B, C, and D. Only the nomenclature has changed. The classification remains same. The nomenclature is now at risk for stage A, pre-heart failure for stage B, heart failure for stage C, and advanced heart failure to stage D, to make it easier to comprehend, as well as to emphasize the importance of stage A and stage B, where we can divert our future forces so that patients are stopped at stage A and stage B, so that we have less and less number of patients stage C. And by classification, now earlier we used to have heart failure with reduced and preserved ejection fraction based on ejection fraction cutoff of 40%. Then heart failure with mid-range EF was introduced by ESC guidelines, which was between, somewhere between 40 to 50%. Now we have additional classification, which is heart failure with improved ejection fraction. This has been with this definition, improved ejection fraction or recovered ejection fraction heart failure has been with us for last 10 years. But now this has been included into classification. Here, to say the heart failure with improved EF, we have to have a baseline EF of less than 40%. We have to document a improvement of ejection fraction by 10%, and the final ejection fraction should be more than 40%. And also stable heart failure has been now labeled as persistent heart failure, with the notion that there is no stable heart failure because these patients continue to have ups and downs. They get repeated hospitalizations and a worsening and improvement in symptoms. So now they are labeled now as a persistent heart failure or heart failure in remission rather than stable and recovered heart failure. I'll skip this one. Whenever we examine a patient, obviously there has to be some clinical criteria for heart failure diagnosis. This is the age-old Framingham criteria, relies on 2 major criteria, 1 major and 2 minor. We have to remember that it has got a very high sensitivity, but it lacks specificity, so there may be more number of false positive cases. That's why further investigations and biochemical investigations are needed. This is a slide from European Society of Cardiology, where they say if there is some abnormality in history or examination, and you do an ECG, if one of these history examination or ECG, if any one thing is abnormal, then patients enters into heart failure diagnosis. Otherwise, heart failure diagnosis is excluded. So if any one abnormality is present, you subject the patient to natriuretic peptide assessment. NT-proBNP should be more than 125 and BNP more than 35. If it is elevated, then you suspect heart failure. It is not a confirmatory test. It is a screening test. Actually, it is not a diagnostic test. If natriuretic peptide levels are increased, then you subject the patient to have echocardiography. Thereby, you can diagnose the patient. You can categorize the patient into heart failure with reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction, depending on whether there is a reduced ejection fraction or there is some LA abnormality or LV diastolic dysfunction or left ventricular hypertrophy. So once you have made a diagnosis, there are certain points which are very important when you label the patient as a heart. First of all, we have to categorize whether it is a heart failure with reduced, preserved, or mildly reduced ejection fraction. And then you have to find out the etiology, whether it is ischemic, idiopathic, or some kind of connective tissue disorder, or anything like that. Apart from etiology, you need to also find out the precipitating factors, whether it is anemia, some kind of tachyarrhythmias, or thyrotoxicosis, as was discussed by Dr. Manjuran. And then you categorize the heart failure as whether the patient is in persistent heart failure or is in recovery So you can have a diagnosis of stable heart failure or decompensated heart failure. And also you classify which class of NYHA the patient is in, whether he is asymptomatic N1 or he is in advanced heart failure or 2 and 3 in stage C heart failure. So these are the components of heart failure diagnosis, which you must always try to find out. So there are a number of causes for heart failure, but whenever we are making a diagnosis, there should be an elaborate effort to find out certain reversible causes of cardiomyopathies. We have to remember this, and we have to always try to find out whether these are present or not. It can be tachycardiomyopathies, alcohol cardiomyopathies, peripartum cardiomyopathy, nutritional deficiencies like beriberi, carnitine, and selenium deficiency. There may be some metabolic disorders like pheochromocytoma, thyrotoxicosis, or severe hypothyroidism, which can lead to LV dysfunction. There may be acute or fulminant viral myocarditis, tubercular myocarditis. These may be also reversible after treatment. And stress-induced or Takotsubo cardiomyopathy is also one of the reversible causes of cardiomyopathy. Natural history, it's very difficult to gauge because it is actually a wide spectrum of diseases. Dilated cardiomyopathy as such is not a disease. It is actually a consortium of different diseases with a different pathophysiological mechanism. Sometimes it is so insidious that it may be the diagnosis may be missed for a very long period of time. Two things are very important, that if there is a short history of symptoms, you may expect that with proper institution of treatment, 25% of these patients may recover and may not land up in heart failure. But if the history is longer than 3 months, you can expect that the patient will land up in severe clinical decompensation and generally has lesser chance of recovery. And interestingly, idiopathic unknown cause DCM usually has a better prognosis as compared to ischemic and other causes of dilated cardiomyopathies. Just to have the Indian perspective, the Indian patients are usually 10 to 15 years younger. They have a higher in-hospital as well as post-discharge mortality. Coronary artery disease continues to be the most common etiology in India, followed by accounting for approximately 70 to 75% of the cases, followed by idiopathic dilated cardiomyopathy, 15 to 20% of cases. Rheumatic heart disease, though it is going down in numbers, but still accounts for at least 10% of heart failure burden. Dr. Rishi Sethi has already covered these slides regarding lack of suboptimal medical management, suboptimal GDMT leads to increase in mortality and rehospitalization rates. And over past decade has been wonderful if you talk about heart failure management with the introduction of newer therapies like ivabradine, ARNI, and SGLT2 inhibitors. The patient's prognosis has improved drastically. So now we have different pillars, at least 5 pillars: ACE and ARBs, ARNIs, SGLT2 inhibitors, beta blockers, and MRA as a base therapies for heart failure. But these are not the only treatment modalities which are available. We have to think about the other things. For example, if the patient is black or if the patient has got a CKD, hydralazine nitrate is a wonderful molecule you can add to the drug. If there is a hypotension, ARNI may be out of question. You may have to resort to ACE or ARBs. If there is associated anemia, you have to correct it with ferric carboxymaltose. If there is some amount of severe MR because of LV dysfunction, you may have to adopt to edge-to-edge repair, either percutaneous or surgical. If the patient is in atrial fibrillation, obviously lifelong anticoagulation is must. Digitalis may be indicated in certain patients. If there is a LBB with wide QRS, obviously device therapies like CRT and AICD may be recommended. And apart from these newer therapies, which Dr. Rishi Sethi has already said, that vericiguat and omecamtiv, though the evidence is not much, but they have shown 8 to 10% reduction in primary endpoints. So probably with more data, they will pave their way into the guidelines. So this is a very wonderful article. I would all recommend all the students, examinees to go through this article, which is a expert consensus on decision pathway of heart failure management. They have tried to give answer to 10 common questions. For example, how and when to add which therapy, how to up titrate, how to modify treatment based upon their blood pressure, pulse rate, and other things. So this is a really wonderful molecule. And then now patient profiling, because your aim is to subject all patients to all the kinds of therapy, but it is rarely possible in clinical practice that all patients are suitable for all these therapies. So we have to find out which therapy will come first. This will totally depend upon patient profile. There are 9 to 11 patient profile depending on low BP, low or high heart rate, presence of atrial fibrillation or CKD. So I would not go into detail in interest of time. I would also recommend that this article, which was published recently in European Heart Journal, the patient profiling in heart failure patients, you must go through this as well. Surgical strategies, I will skip. So now coming to learning from cases, just a few relevant, it's very difficult to point all the things which you have learned. It was all the points raised by examiners were pearls of wisdom. Just to make certain points, for example, palpitations. When you're taking history, you have to have a holistic approach. You cannot just have the symptoms which patient has told you. You have to find out the other symptoms which patient usually present with. For example, I talked about reversible cardiomyopathies. So you have to ask whether there was certain palpitations. You would like to rule out any underlying arrhythmias. And you would also like to rule out other extracardiac features which are actually contributing to the cause of symptoms. For example, anemia, thyrotoxicosis, cachexia, or any bleeding episodes because patient was already on antiplatelet therapies. Hibernation versus stunning. Obviously, it was pointed that the only difference is actually that the stunning is acute phenomena while hibernation is chronic, and stunning has got perfused arteries while hibernation, the myocardium is actually ischemic, and it is a protective mechanism in response to a chronic ischemia. PND mimics, here the cuff was actually a PND mimic. So, and also PND is a very favorite question of all the examiners. So I would say that all the students must learn the basics, causes, various mimics which can confuse you with paroxysmal nocturnal dyspnea. And as very rightly pointed by Dwivedi sir, that all the patients, whether they are MI or heart failure patients, they must be risk stratified. And based upon this risk stratification, they should be counseled and appropriate therapy should be instituted so that they don't land up in complication and their will to come back for follow-up is actually maintained. Going to examinations, one should be very methodical. You cannot miss points and your physical examination findings cannot be discordant. JVP and pulse are must, and they should be mastered by all the students. For example, Mockenberg calcification can be easily pointed utilizing the Osler's maneuver. Summation Gallup, you can also have some indications in the patient's ECG. S2 split. In auscultation, we always forget about split. So this is something you have to master again. S2 is very favorite. You have to find out, not only examine, but you have to have different interpretations ready, whatever the findings you have. Same is true for S3 and S4. So one more thing, diagnosis. You have to be prepared with diagnosis or differential diagnosis at 3 stages. First is at the end of history, then at the end of examination, and after your workup, for example, basic investigations like ECG, echo, and any other investigations which we have. So you cannot just have differential diagnosis at the end of case. You have to have differential diagnosis only from your history and then examination and then investigations. Investigations, I will skip, sir. In investigations, yes, as rightly pointed by Dwivedi sir, deceleration time is really sensitive. It may be even more specific as compared to E by E prime if you want to have estimation of PCW. And also, whether you are examining a dilated cardiomyopathy case or congenital heart diseases or rheumatic heart disease, there will be a time when you will be asked to have a pressure estimation based upon your examination findings and your echo findings. So you must master this technique as well. So thank you so much. I will end my talk here, sir.
Thank you, Dr. Pravesh. I think there is only one question in the chat box. Because once heart failure sets in, the mortality increases drastically. Should we focus on strategies to prevent heart failure? Comments from the panel of examiners, experts.
In fact, the basic American College of Cardiology guideline, they start with the same basic, and that is why the classification has been there. The stages of classification, stage A and B, that is very pertinent. So I think complete management of heart failure should start from prevention. Definitely, there is absolutely no doubt about it. I fully agree.
Now, Melo, what is the question? Can you repeat the question?
Sir, once heart failure sets in, the mortality increases. Should we focus more on strategies to prevent heart failure? That is progression from stage B to C. Probably that is.
I think that has been well covered by the speakers.
Yes.
I think it is extremely well covered. Pravish has covered extremely well. And, I think the question has already been answered.
Okay.
If the students have got the doubt about a clinical finding, they can ask now so that that can be clarified. Otherwise, I think we'll have to close the session.
Sajan and Arun, can you close?
I think that's also that's the only question we've had. I think I should thank everyone for this wonderful academic session we have had. The 6th program after a break of 2 months. I should thank Professor S.K. Dwivedi and the entire team from KGMU Lucknow for taking the heart failure session, the clinics so well. Dr. Rishi Sethi for the introductory talk, and Dr. Pravesh Vishwakarma for the take-home points. I should also thank Dr. Swati for the very good case presentation and also for sharing the clinical slides. I mean, the case discussion slides for the first time. And thanks to Taragan sir for that suggestion as well. I should thank Dr. Anil Bhatt sir, Dr. Taragan sir, Dr. Manuran sir, and Dr. Dwivedi sir again for being the examiners for this event. Should thank Dr. Kamlesh Kumar, Dr. Valsal Singh, and Dr. Ritesh Kumar from JIPMER Pondicherry. They've taken the hot seat and done excellent work and answered the questions pretty well. So it is good work to the JIPMER team. And I'm happy to say, I mean, because I'm also affiliated to, I did my MD from JIPMER, so it's something that's just reminds me, so that's good from there. And thank Chopra sir for for giving us this platform and this opportunity for Harishan sir to take this to this level we've reached. It's a national level program that's been going on excellently well. Thank you, Venu sir, for he was there for all through this program and even for the trial session as well. I think on all the trial sessions as well, sir is the first person to log in. Sometimes I feel embarrassed when sir logs in before me, but that is the enthusiasm which Venu sir has been doing. And thank you. I must mention a special word of appreciation to Dr. Sajan Ahmed sir, for I could say brother in action. He is there throughout for the support for preparing the program. I should thank all the delegates for having attended the program, and Ritesh and Co for the audiovisual work, and Vinay for the Vinay and his team for the brochure related work, and also Mankind Pharma for the support we've had throughout. So thank you all for joining this program.
The next program is on September 11th. The roles will be reversed. Here the students will be from JIPMER presenting the case, and the KGMU students will be the student panel.
Hari, do you have any idea how many students on a national level are attending this program?
I didn't get the information, sir. This time it may be low because the exams are over and the people are relaxing now.
Oh, is it?
Yeah, correct. You're absolutely correct.
Exams are just going
I
on.
think KGMU had the exam last week, no, sir?
Yeah, yeah. We had last week.
Generally, the attendance has been very good.
I have to get the information. I think I didn't get any this thing so far.
Yeah, so
Okay, thank you, everyone. Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you. Thank you.
Thank
Thank
you.
you. Good night, sir. Thank you. Thank you.
Thank you.
Very nice.
Thank you.
So, Hari. Arun, great job as usual.
Yes, sir. I think Venu sir and Haryushan sir have now taken this to to a big level, and
No, I think the growth has been fantastic. Hari,
Sir.
I think again a wonderful session.
Yeah, so I was writing all the notes about
all the things that we didn't know.
yeah.
I tell you, these guys,
so
they
many
are
points
like a
to ask the
mind of
future students. Many points so that I clarified myself.
Yes,
So that,
same here. I also got a paper here.
yeah, I have a diary for this. So.
yeah, it's in the mobile here.
Okay, Hari.
Rajan.
I wrote a note to Mandeep Mehra.
Sir.
You saw that, no? I copied you in that.
Yeah.
So he replied saying that he was busy with his clinic and he's going to get back.
Yeah.
That is one program which has to get back on track. The other thing is we've been approached. I told you about CIPLA.
Yeah, CIPLA. Yeah, I think.
So they have clarified.
Our next this thing is I think I discussed with Dr. Tiny yesterday. So he said he will give it in 2 weeks time. So they almost the issue is ready, except or not. I have to give my article also.
Right. So
I think that is ready. The supply is ready to sponsor 2,000 copies, and they will send it across cardiologists.
Right. So
that's
next week, 3 of us will have a meeting, Zoom meeting with them. They called up today.
Okay.
So, yeah, so we'll have a meeting next week to finalize things further. They are also interested in supporting some other programs also.
Yeah.
Chalo, good.
Okay, sir. Good night. I think attendance. I think Mankind. Who is there from Mankind?
Sir, I'm there, Ritesh.
Yeah, Radesh, I think the attendance, I think you have to take care. I think the attendance was not good.
Yes.
How much was it?
How many?
128, isn't it?
Huh?
128, isn't it?
Yes, sir. It increased to 134. 134 is it is showing right.
But generally our attendance has been 400.
Yeah.
Yes.
I think we have to do some campaigning next September 11th.
With such good teaching programs, you have to get more people involved.
Yeah,
Right.
I think we have to give some more publicity. I think
Sure.
probably we were after there is a fatigue after the COVID, so probably we will recover next time. So
Sure, sir. Sure.
we should approach around 1,500 postgraduates in all over this thing. And we have around how many postgraduates? 600 seats per year, no?
Yes,
600 DMs into 3, so it will be 1,800. So at least we should get some 500.
Yeah, 500 should be attending, and maybe you can.
I think what you can do is you can give it to MD students also, so they can also benefit.
Okay, sir. Okay.
Yeah, I think
I've been sharing it to MD Medicine and MD Pediatrics in my contacts.
Hari,
groups also
can we in the communication with DM students or DMP students, can we give them a small snapshot of what we have been doing so that they get interested? Just inviting is different. But if we say that,
I think we can ask Vinay to make a brochure where what all the cases which we have presented, and I think we can make something like that and the examiner
also,
panel.
also the names of examiners, etc. You know, because that kind of gives them the incentive that, you know, these are the people who are going to be examining us.
Yeah, I think we can put the examiner panel and the cases discussed.
Cases
So
discussed.
that,
Examiner
so
panel.
that we can make a attractive brochure, so that we can send along with the next brochure. Okay.
Yeah, the publicity has to get a little bit better.
Yeah.
Sure, sir. Sure. Sir, we'll ask our team to follow up a little better this time. Right?
Yeah, I think it is okay after the COVID. 128 is not that bad, but then after the exams are all over everywhere, so people are not that keen. But I think we will get more people.
Sure, sir. Sure.
And not only through emails, but you have to go there in person and invite, put a notice there in their PG room or something. You can enter some of the postgraduates to put a notice so that people will.
Right. Right. Sure, sir.
Okay. Good night.
Okay. Good night, sir. Good night.
Good night, sir. Good night, sir.
Thank you.
Shahjan, what happened? He was not well.
He was there in between. Arilla.
Shahjan എന്ത് പറ്റി?
ഒന്ന് വിളിച്ച് നോക്കാം എന്ത് പറ്റിയെന്നുള്ളത്. സാർ, അതുപോലെ നമുക്ക് കേരളത്തിൽ നിന്ന് അറ്റൻഡൻസ് കുറെ കൂടെ കൂട്ടണം സാർ, എനിക്ക് തോന്നുന്നു.
Okay, ഞാൻ വിളിക്കാം സാധനം വിളിക്കാം.
Yes.
Good night. Okay, Ridesh, good night. We are leaving.
Good night, sir. Thank you, sir.
Good night. Thank you.